for balance training older adults. Ryan, talk to us.
Yes, sir. So my name is Ryan Glatt. I work at a place called the Pacific Brain Health Center in Santa Monica, California. We see all sorts of individuals with neurological concerns and conditions, from people who want to prevent cognitive decline to individuals with mild cognitive impairment, dementia, Parkinson's disease, multiple sclerosis, etc. I have about 10 years experience in the fitness industry, very close to being done with a master's in applied neuroscience. I'm the author of the Brain Health Trainer course that is carried by FAI, and I am more than happy and excited to be speaking along one of the coolest people ever, Dr. Chris Thompson. And it was a year ago that we got Jimmy John's together in Albuquerque. Right? Last year at the FAI Summit.
You and Evan Osar to Jimmy John's. It was the greatest meal of your lives.
It depends who you ask. So it was great. It was great. And together we are perfectly balanced. Pun intended. We do feel that way. So let's move on here. Let's go over the objectives. So objective number 1 is to understand the value of brain health and balance separately and collectively, how brains and balance are affected by aging and why that is no bueno, and how to assess and program for brains and balance, our secret sauce. What we want to make sure is that we're going to spend a lot of time on assessment. We feel so many people are so keen on programming, techniques, what can I do tomorrow? But so much rides on assessment to be able to demonstrate changes. And we're going to talk about the value of assessment and the role of both brain health and balance.
Yeah, we want to ensure that we're not just using assessment to gather some data and to show numbers to our clients, or just feel like it's an element that we need to go through at the start of working with somebody. Really, assessment should drive programming. It should drive very important decisions that we're making in terms of how to construct our programming, when to progress our programming, when to regress our programming, when to introduce new elements, and things of that nature. So it'll be interesting as we talk about assessment. We'll go through assessment of balance, and obviously the physiological mechanisms that control balance will determine how well somebody does on an assessment. But then also when we add on top of that some cognitive challenges, you'll see really how cognition and balance and the physiology and the neurology come together. And by gathering that info, it will inform you to know better when it's time to introduce or add to challenges that you're already providing your clients.
Indeed. So let's play a quick video here.
Oh yes, Larry David.
I'm Larry David. Obviously somebody put me up to this because it's generally not the kind of thing I do, but I basically want to address the idiots out there, and you know who you are. You're going out, I don't know what you're doing, you're socializing too close, it's not good, you're hurting old people like me. Well, not me, I have nothing to do with you, I'll never see you, but you know, let's say other old people who might be your relatives, who the hell knows. But the problem is you're passing up a fantastic opportunity, a once-in-a-lifetime opportunity to stay in the house, sit on the couch, and watch TV. I mean, I don't know how you're passing that up. Well, maybe because you're not that bright. But here it is. Go home, watch TV. That's my advice to you. You know, if you've seen my show, nothing good ever happens going out of the house. You know that. There's just trouble out there. It's not a good place to be. So stay home and you know, don't see anyone except maybe if there's a plumbing emergency. Let the plumber in and then, you know, wipe everything down after he leaves. But that's it. Okay.
So Larry David is certainly an acquired taste. Chris and I like him a lot. But, you know, this was a PSA for COVID. But the reason we're showing it to you is, one, we love Larry David. But two, it's almost it's funny, but on the other side, there's a dark side to the humor behind what he's saying. We feel, at least non-COVID specifically, when people have a high risk of falls, or they're afraid to leave the home, or they have cognitive impairment and they socially isolate. He said something, don't go outside, just stay inside. You don't want to go, you know, that's how people actually feel, COVID or otherwise, when they're at a high risk for falls or having cognitive decline, right, Chris? And it's humorous the way he puts it. He's of course talking about COVID, but you know, and right now I think it's even more concerning for the older adult population to be receiving balance and cognitive training for several reasons. One, they're not maintaining perhaps the level of conditioning or appointments or going out and about that they were in the real world. And therefore they may be losing functional and cognitive adaptations and certain aspects of health. And it's further ameliorated by social isolation, stress. So this population needs us right now, right, Chris?
There's no question. And hey, where do most falls happen?
In the home.
Most falls happen in the home, of course, because we spend a lot of time there. But the more time we're spending inside, isolated, it definitely is not a positive for the overall health and well-being of our clients. So we want to ensure that if they are spending time inside, we're also challenging them and getting them to engage in meaningful, appropriate, and challenging exercise. So that's hopefully what we're going to.
Once you do start going outside,
don't do this.
Yes, exactly. Once you do start going outside, you're going to want to train balance for this.
Jetzt kriegt er den Ossen runter. Schön langsam. Jetzt geht er. Jetzt geht er langsam. Jetzt kommt er langsam. Eine müssen noch nicht. Wir werden noch Können wir doch lachen? Ich meine, also einer muss lachen. Nein, der Böse. Kilo. Stramm stehen. Wo steht er? Hey, bitte. Kilo. Komm gut. So langsam. Nein, nochmal, der kommt auch noch.
Taurus, man, what are you going to do?
Not good. So clearly, you know, there's this element of progression and ensuring that we are providing the right level of stimulus and the right level of challenge for our clients. I'm not exactly sure what made these folks think that it was a great idea to do a human seesaw when they're 10 feet up in the air. But obviously they gave it a shot. And really, when it comes down to it, this masterclass is about brains and balance. And in order to stay balanced, you need to use your brain a little bit. That might not have been the best idea for an activity.
And Chris, I heard you're hanging out at this trailhead for clients now. Is that right?
Absolutely. I took that video and I just started passing out all my cards right there. Okay, so folks, we want to get started and really provide just a lens through which we can look at the integration of these different physiological parameters that we're going to discuss today. Because, you know, you might be thinking, well, the brain and all the changes to the brain and some of the functional deficits the brain acquires, well, that's kind of on one side, and we have to worry about that. So we should be telling our clients to, you know, do crossword puzzles or stay active with current events and engage the brain in some way. And then all the body stuff is on another side of the equation, and that's where we work with them in the gym. So it's interesting when we start talking about the integration of these two concepts, and a good way of emphasizing the fact that it doesn't matter what system of the body we're discussing, we see deficits occur as we get older. So we've got what's called the classic aging curve here. This was really popularized by a colleague of mine, Joe Signorelli. He's on faculty at the University of Miami Medical Center. And he's been studying geriatrics for a very long time, kind of the gerokinesiology world. He's a big strength and power training guy and has done a lot of research. And the best way to just show what happens to an older adult as they go through the aging process with or without meaningful exercise as an intervention can be summarized in this curve. I mean, obviously early in life during growth and development, whatever the physical parameter is, in this case, I'm using limits of stability, which is a measure of the ability for a person to maintain balance in a static posture. We see how many centimeters they can move their center of pressure across the surface of their foot, either anterior, posterior, laterally, medially. And that's quantified in centimeters. And we see as a person grows and develops, they end up getting more muscle mass, they end up getting more motor control capabilities. We see that the ability for somebody to control their center of pressure and limits of stability improves over time, even if they aren't actively pursuing a training program which may challenge limits of stability. It's just growth and development and maturation, which allows them to get better as they develop further. Then, once they reach adulthood, the goal is to maintain that level of function that they were able to get to during the growth and development stage. And then as we get older, we see that there is a slow or possibly an accelerated rate of loss of these physiological parameters. In this case, limits of stability, the ability for somebody to control their center of pressure during postural sway or during any other movement of their center of pressure. Maybe they get bumped into by somebody or they're reaching for something. We notice that that begins to decline just as a result of the aging process. Now, what's interesting is the effect that physical activity and meaningful exercise interventions can have, because any parameter that we talk about physiologically can result in something bad happening to us. So in this case, our disability or our bad incident that could occur with poor limits of stability is fall risk. So once somebody gets to a very low capability of being able to move their center of pressure and has a low limit of stability, the likelihood is that they are going to fall at some point because they won't be able to recover their balance rapidly enough if it's disturbed. Now we notice that people who are more active follow that orange curve trajectory, whereas people who are less active follow the blue curve trajectory. In other words, the people who follow the orange trajectory and are regularly active, they might never really even reach the fall risk threshold. We probably don't have to worry about them falling until they're in their late 80s or 90s, when perhaps something else is what causes a problem in their life. However, if they don't focus on developing and maintaining this balance control parameter, the ability to move limits of stability effectively, then they may reach this fall risk threshold in their 60s or 70s, and they may become a sequential faller or a serial faller through later in life. So this concept of an aging curve is really a way to just show that multiple parameters in our physiology change over time and emphasize the importance of intervention. Ryan, I think you have something similar to show for cognition, right?
Why, yes, I do, Chris. Thank you for asking. So this is a curve demonstrating cognitive decline over the lifespan. There are many ways this can go, and we hope it goes well, right? But for a majority of the population, indicated by the epidemic that we're currently facing of cognitive decline, which we're not going to get into epidemiology. It has to do with population size. It has to do with healthcare, people living longer than they ever have before. But there's many, many different factors. But the point is that there is a significant increase in the amount of people with cognitive impairments and dementia now and exponentially into the future all around the globe. So how does this process actually occur? What are the changes that occur with aging? Well, there is normal aging, and there is slight cognitive changes in certain cognitive domains like processing speed, certain types of executive functioning, certain types of memory, even visual-related cognitive processes or sensory-related cognitive processes that normally occur with age. Now, you could say this is true for the body as well, and certainly the more aggressive, in a good way, our interventions are, the more we can deter even those normal processes from happening, but they likely will happen. Now, if you are on the green line at the very top, that's probably the best case scenario. If you're at the one below that, it's not bad, it's not the best, but it's still pretty good. And then if you're at the blue one, well, it's probably the likelihood that you are being, your cognitive decline is being contributed by various risk factors, whether they be genetic or lifestyle or environmental. So we're not going to go over what goes into cognitive decline, but one of the first phases is preclinical. Now, it's preclinical because you're not in the clinic. You're not getting assessed. You're not getting diagnosed. And this is true for most people. Another word that we could give it is subjective cognitive decline. It's very difficult for people to differentiate between what is normal cognitive aging and what is suboptimal or beyond the normal cognitive aging or abnormal. So within the preclinical phase or the phase of subjective cognitive decline, which is likely where most of your clients are going to be at if they express cognitive complaints, they're going to have brain changes, whether they be structural, functional, or cognitive, without measurable symptoms. So they may notice these changes. Oh, I'm not as quick as I was. I'm not memorizing names and faces as well as I used to. But those changes usually are not that detectable on tests. And if they are, they're not significant. So it's a stage where the patient, or in this case, yourself or your client, does know there's some slight changes, but the doctor doesn't. We're not going to talk about how to differentiate between normal cognitive aging and subjective cognitive decline, which is a condition that's just not diagnosable. Then we have MCI, mild cognitive impairment, in which there can be many different types. The reason I'm going to break down the types is because they have specific implications in falls. So there's amnestic MCI, and amnestic is a fancy word for memory loss. Multi-domain is the decline of executive functions. We'll describe those, but individuals with multi-domain MCI seem to also be at a higher fall risk. So mild cognitive impairment has to do with cognitive changes that are of concern to the individual or the family, and they are detectable on cognitive tests. It is a diagnosable condition. The reason MCI is important is because it usually precedes dementia, in which there can be many different types. And dementia can be defined as cognitive impairment severe enough to interfere with ADLs or activities of daily living. There's many stages of dementia. There's many types. The most common one, about up to 80% being Alzheimer's disease, but then there's Lewy body dementia, vascular dementia, mixed dementia, and we could go on. So the idea is that most of the time, we're going to have people either with normal aging or subjective cognitive decline. And that is where we need to start addressing these people to influence this curve in a positive direction as much as possible. If we have people with MCI, according to statistics, it's very likely that that person may have not been diagnosed. So they may not know they have MCI. So first and foremost, if your clients have cognitive concerns or you notice cognitive changes and you're not sure if they're normal or not, it's very important to refer to neuropsychology or a geriatrician or to a doctor for a memory evaluation. Over 65% of older adults 50 and up think it's important to have a cognitive assessment, but only 13% actually get one. So with the personal trainer or the fitness professional being a conduit in the community, I think we're at a unique opportunity to be able to refer to doctors, one for business reasons, but two for also the ability to have early detection of cognitive decline, which if we did that alone would save the healthcare industry trillions. So it's both with cognitive decline and with falls, they're probably some of the most expensive issues and crises that we have, and they're not stopping. They're going to exponentially grow. So what the opportunity is to address both of them, to assess both of them, and also program for both of them. Chris, is there anything you want to say about that before we move on?
Excellent point. I mean, I think that in the light of our world currently facing a pandemic, we have to recognize that both cognitive decline and falls represent two interconnected epidemics. I mean, we're talking millions of people in the United States and far more than that worldwide have either been diagnosed or will soon be diagnosed with dementia.
Or at least you'll know somebody that has been, either in your family or in your circle of friends or your community.
Same thing with falls risk and falls occurrence. I mean, almost every older adult has had an experience with the fall. Maybe it's been a non-injurious one, or they know people who have been significantly injured. These lead to direct medical costs in the billions or trillions of dollars. Yeah. So we really have to recognize that these two elements that we're discussing today, and we're really trying to bring together in terms of an integrated approach to training, have such a substantial effect on older adults in our communities, our countries, and even worldwide.
And it's a chicken and the egg conversation, not chicken or the egg. So if someone falls, that can contribute to more cognitive decline. And if someone has cognitive decline, that can contribute to more falls. And so there's other comorbidities that can be involved, especially things like polypharmacy or hypnagogics, in other words, sleep medication, which a lot of people are on. That can affect both cognition and fall risk at the same time. And so they're interrelated in a way that is very critical. Or at least it makes it critical to intervene and assess. But, you know, the frustration that Chris and I have had is most people are talking about these things separately, but not in an integrative fashion. So that's what we're excited to do today. But before we do that, we got to start with the what I think to be the foundation of this, which is understanding balance and gait, right?
Yes, absolutely. So we're going to go through a primer on balance and gait. And, you know, the reason why we're talking about balance and gait, and obviously our goal is to provide a lens through which we can see the connection between physiological function and neurological function. Physiological function, how the parameters that we are trying to modify when we're in the gym with our participants, we're trying to get them stronger, we're trying to get them more mobile, more stable, better balanced, improve their gait, improve their posture, reduce their pain. There are so many things that we try to do when we're working with our clients. We wanted to choose two very cognitively challenging or cognitively requiring tasks or parameters, phenomenons that would really help to demonstrate the close connection between the brain and the body. So balance and gait are the two elements, the lens through which we're going to look at this interaction between the physiological and the neurological today. So what we're going to start with, just kind of this concept of balance. It's a very complex phenomenon. You know, I mean, I have some fun when I'm at my University of San Francisco classes, and I ask students that come into my physical activity and aging class, I ask them to define balance. And because, you know, they can define muscle strength. Oh, it's the maximum amount of force that a muscle or a muscle group can produce. They can define things like speed, you know, the maximum velocity that a person can achieve while running, those sorts of things. But when I ask them to define balance, it's really difficult. They're like, well, balance is sort of being balanced. Balance is not falling. But balance from a contextual standpoint or from a definition standpoint involves so many different things. It involves contextual effects, it involves the musculoskeletal system, and it involves the nervous system. An interaction of these three parameters. Oftentimes we'll look at a model like this. This is very similar to, in motor control, what's called the dynamic systems framework. The interaction of three seemingly sort of disconnected areas that all have incredible impact and effect on one another, and can lead to the ability for somebody to have or express good balance or have or express bad balance. So as we go through this little schematic here, clearly the nervous system, getting input from the body, so bottom-up input. So there are a number of receptors and sensors and things that we're going to talk about momentarily that provide information to the central nervous system about what situation the body is in, what sort of stimuli the body is reacting to, and what sort of motor responses the central nervous system needs to develop in order to successfully handle whatever that situation happens to be. That's very important. So the nervous system is constantly receiving inputs and programming outputs. Those outputs are coming to generally the musculoskeletal system. So in the musculoskeletal system, we need to have muscles that function effectively both to produce force and to produce power, because oftentimes for someone to keep balanced, it means they need to recover their balance when it is challenged. Maybe it's a stumble, maybe it's a trip, maybe it's a perturbation, somebody bumping into them. The musculoskeletal system needs to be functional enough to be able to handle all of those different contextual situations that will allow the person to be balanced in that particular situation. We also, from the musculoskeletal system, are sending information through our sensors, our sensory systems, to the nervous system. And then we have the contextual effects, the environments that we're in, the activities that we're doing, the tasks that the body is needing to perform. And it's interesting, balance can be very different depending on the context. So if we're thinking about static balance, somebody is reaching for an item on a shelf, or reaching to get something out of a closet, or reaching to try to avoid some object that's coming at them. That is kind of a static balance context, and staying balanced in that situation is going to look very different than staying balanced in a totally different context. If somebody is walking or running or playing a sport, the task characteristics of walking, running, playing sport are dynamic. So their ability to keep balanced and observing balance is going to look a lot different in a dynamic situation versus a static situation. So you can't just say that balance is being able to stand on one foot, or balance is being able to walk without falling down, because the context in which we have to express balance result in balance looking very different depending on where we are. So these three components are constantly interacting with one another. And ideally, if they're all interacting in the most optimal way, the person is going to be balanced and they are going to be successful at whatever activity they're engaging in. So it's a really complex phenomenon. Ryan, do you have anything you'd like to add there?
Yeah, I do. I really like looking at this chart, almost if we could use each of the three systems, the nervous system, the contextual, and the musculoskeletal, and then using those subdomains that are branching off there and thinking about certain clients and being able to check off where you think you are training them well in one of those subdomains, checking off where you think they really need something, right? So for example, we can take care of the nervous system in every sub-branch and the musculoskeletal system in every sub-branch, but then the lighting in their home sucks, or they have a carpet or a rug that can easily slip, right? And just those things that are so simple contribute to these air quotes stupid falls, things that shouldn't have happened or things that could have been prevented. But if a health and fitness professional really knows these subdomains very well, I think they can be a powerful force for preventing falls outside the context of a fitness session. I think that's really important. We become not rep counters or timekeepers, but manipulators of the environment to prevent falls as much as possible. And I like how this would allow for something like that, or at least a nice cognitive model for doing so.
Agreed. Okay, so sticking with the physiology side of things, let's talk a bit about our falls defense systems, which ultimately, unfortunately, get worse as we get older. So, there was a researcher back in the 1980s when balance and fall prevention started to become a little bit more mainstream. We started to recognize that, hey, older adults actually can adapt to training programs. They can get stronger. They can get more powerful. They can increase their cardiovascular endurance. They can improve their balance parameters. Researchers started to really look and see what sorts of stimuli or stressors are out there in the world that can lead to falls. And Mary Tinetti, Dr. Tinetti, after whom there are a couple of assessment protocols named after the Tinetti Balance Scale and some other things. Mary Tinetti, she's at Yale University, and she did an analysis of the number of risk factors that exist out in the environment and out in the world that can predict somebody falling. And she came up with over 160 different independent risk factors, some intrinsic to the body, such as poor eyesight, poor hearing, poor musculoskeletal strength or power. Others external to the body, such as environmental conditions, as Ryan mentioned, lighting, perhaps clothing and loose or inappropriately fitting clothing, things like that. There's so many different factors. And now, given the advent of more technology, such as iPhones and things of that nature, there are probably even more risk factors that lead to us being less aware of our environments because we're engaged in other things. So we've got 160 plus risk factors that can lead us to falling. And we only have 3 specific falls defense mechanisms within our body. And these are very small systems, and they tend to get worse as we get older. So it's kind of a bit of a double whammy. It doesn't seem like a fair fight. 160 risk factors, 3 little defense mechanisms, all of which tend to get worse. So we have the vestibular system, which is in the inner ear. We obviously have vision. The majority of people use vision as their primary factor to help them maintain their balance. We can easily see that when we remove vision during a balance task, have somebody close their eyes, or have somebody track an object that isn't related to maintaining balance in that situation, and their balance goes right down the tubes. And then also we have our somatosensory system, which is basically nerve endings and receptors that exist within our skin, our muscles, and our joints that provide incoming input to the brain in order to let the brain know and the central nervous system know what sorts of contextual situations we're in, what sort of surface we're moving on, and what sort of, if there are changes in elevation or changes in friction, those sorts of things. So, and each of these 3 systems starts to exhibit biological aging. So not only do they age from a non-use or a disuse standpoint because we're getting less fit, they actually just age because they are complex structures that as we get older start to lose their capabilities to a degree. So we're going to talk about them a little bit. Ryan, go ahead on to our next slide. And this is really kind of a way to envision these 3 different balance control mechanisms in terms of how they inform the central nervous system about the condition the body is in so the individual can maintain their balance. So down on the bottom left, I've got a rectangle around the somatosensory system. This includes receptors that are in the skin, the cutaneous receptors, in the articular or in the joint structures of the body, and also within the muscle, that would be your muscle spindle, and even in the tendinous attachments, which would be our Golgi tendon organs. Those receptors are constantly monitoring the positions that the body are in, from what sorts of environments they might be standing or moving on, what joint angles the person may be at, what sorts of forces the body is encountering from a pressure, a touch, a stretch perspective. And we're constantly providing that sensory input into the spinal cord and up to the central nervous system, up to the brain. So, and then on the flip side, we have further up in the head, we've got the eyes and also the inner ear. So our vision and our vestibular system integrate together. They inform one another. They inform the brain of what situation the body is in based on what we're looking at and what direction our head is moving, whether it's through turning our head or accelerating or decelerating the motion of our head in different directions. So the visual and the vestibular systems integrate together. And as long as their information is essentially similar and they're providing info to the brain saying, okay, I am moving in this direction, my eyes see me moving in this direction, my vestibular system senses me moving in this direction, the brain can sort of figure it out and then develop motor outputs to all of this incoming sensory information to be as successful as possible in order to ensure that we stay balanced in that particular situation. So this is really what we call sensory motor integration. We have sensory information coming in from the body and also from the head into the central nervous system. The central nervous system is gathering all this information, attempting to figure out what that means in order to determine what the best motor or movement strategy should be to handle that particular situation, whatever context we find ourselves in. And then we send the appropriate motor response out. So that's sensory motor integration. And these three systems play a humongously important role in effective sensory motor integration and therefore movement quality and motor control. Ryan, do you want to add anything?
Yeah, so specifically what I'll talk about is the cortex and the cerebellum. Certainly the brainstem is that bridge between the more cortical cognitive networks and the more automatic reflexive ones. And it's also the bridge between the peripheral nervous system and the central nervous system, even though it is a part of the central nervous system. The cortex and the cerebellum is likely where I'm going to spend a majority of my time. But I think before we jump into that, what we can appreciate is the bidirectional relationships between these two things, or not two things, but all these things. So there can be various hiccups in the process, right? It could be a hiccup in the muscle tissue. It could be a hiccup in the visual input, the vestibular input. It could become a hiccup in the central nervous system, where there's the cerebellum and the cortex not having enough function or size issues with volumetric changes in the brain that can occur with aging or a neurological insult like a traumatic brain injury or a stroke. So really, even as a air quotes expert, it's a marveling thing to look at in terms of the complexity of the interaction between these systems. Hashtag National Geographic. Back to you.
Oh yeah. Oh yeah. So briefly touching on the somatosensory system, we have a number of receptors in the periphery of our body, and they are sensitive to a number of different stimuli, external stimuli and also internal stimuli. The most important of which, when we talk about balance and gait, is our touch receptors. The receptors that exist within the skin, within the articular structures of the body, that are able to determine kind of, okay, what sorts of pressure is the body responding to? What sorts of surfaces is the body walking on? And those touch receptors are very sensitive to provide input to the central nervous system so that we can respond currently to what we're experiencing and also have anticipatory motor mechanisms occurring. Because let's say you're walking on a nice smooth surface, but you see several steps ahead that turns to gravel, or maybe there's a puddle or something that looks slippery, a patch of ice ahead of you. You are seeing that via your visual system, and you're integrating your current information coming from a somatosensory system along with your anticipatory information coming from your visual system. And then that will kind of, again, get processed in the central nervous system so that in real time, a person is able to modify their movement strategies from kind of a safe, more casual movement strategy to a more guarded and more appropriate movement strategy when they encounter a more challenging situation. So just this information coming into the body from the somatosensory receptors, from a touch perspective or a pressure perspective, provides a really great amount of input from which then we can plan the most appropriate motor response. And then obviously there are other things too. We have pain receptors, thermal receptors, chemical receptors, and they all also inform the central nervous system so that modifications can be made in other areas that might not be motor or movement related. Moving on.
I muted myself, but I did want to say something about this. So, I think we talk a lot about social isolation and how detrimental that can be for cognitive decline. But also somatosensory isolation. And this is especially true for people who don't get out of the house, who aren't around a lot of people, who are maybe more isolated than not, and perhaps omit themselves from sensory-rich activities. And as we age, there's normal changes that occur to these sensory systems. But, I do feel that a majority of our clients may be or at least the ones that could be our clients that really need us, really have this somatosensory isolation, and they need us to create these sensory vitamins, if you will, to enrich their nervous systems and keep them fresh. You know what I'm saying, Chris?
Absolutely. Yeah, there was a a very interesting architect that lived in Japan that created sensory enriched houses for people.
Oh, yes.
And had all these weird foams, different densities of foam around the house and different bright colors, and really ultimately was geared toward providing a wealth of somatosensory input. So even if somebody were in their house where typically everything is very predictable, it created a much more enriched environment. And it was demonstrated that people actually had better balance control, better postural control, and less falls when living or experiencing that environment for a period of time versus those that were kind of in a more drab or basic. I mean, it's almost like putting a mouse in a cage without a wheel and without interesting toys to play with versus having the mouse have this really enriched environment. And we see such better responses in those situations.
It's also true for brain health, where people in senior living are integrating these sensory rooms. And, you know, it may not directly target cognition, but through improving quality of life, through improving the sensory input into the body, into the brain, there certainly is an indirect effect on cognition and brain health. And within those animal studies where they just restrain animals from all sensory input, they have significant negative brain changes that occur. And so that's been demonstrated in humans to a degree as well.
Yeah. And a great example for humans, Ryan, is just the fact that, we have a number of different sensory systems. If somebody is hearing impaired, so they're losing one of their primary incoming sensory systems, what does that do specific to cognitive health?
Well, I'm glad you asked. I threw in a surprise slide in the next couple just about that. It's almost like we're doing a webinar together. All right.
Oh my gosh.
So,
crazy.
I think we've talked about this. Perhaps you want to comment on the physiology of it a bit more?
Right. So, you know, obviously one of the biggest issues that is going to affect somatosensory input is really looking at those structures where those receptors exist. Okay. So those receptors exist within skin, within muscle, and within joints. And they tend to respond and get turned on and provide information to the central nervous system in response to motion, in response to movement. So if we have joints that are very stiff, that have lost their mobility, if we have muscles and connective tissues that are very stiff and have lost their ability to produce movement, then we greatly reduce the amount of somatosensory input that's coming into the central nervous system, just due to the fact that we have had structural changes occur through inactivity to these very important somatosensory locations. And so it's super, super important to ensure that we're encouraging physical activity in order to maintain motion within these structures, to ensure that we're having the sensory input being maximized so that our motor outputs can be most appropriate. So it just, even something like a dynamic stretch can do wonders for sensory motor integration from the somatosensory system and provide better motor outputs. So, you know, I think that always having as much dynamic motion in our exercise programming strategies is super important, because it continues to maintain the integrity of our somatosensory system doing the best job it can to inform the central nervous system.
And I would argue that that type of example of a dynamic stretch improving the sensation and qualia of that experience, those mechanisms are primarily neural, where so much of the fitness industry is focused on the structural changes. And I think the one metaphor that we can give connecting the brain and body is that people have been talking a lot about fascia and muscle tissue. And, you know, we create this image that things are structurally changing as we're giving these acute inputs. And the same mythology applies to the brain, that yes, we have this ability to change structure, but just like muscle hypertrophy, it kind of takes a while and it takes some effort. And people imagine, oh, every time you're doing something that's an input, the brain just grows like a sponge and new neurons pop up like mushrooms growing from a wet lawn. You like that metaphor? Very poetic. And, you know, that's right. But the reality is that these are functional neuroplastic changes and less structural neuroplastic or structural neuromuscular changes, right? Or muscular changes, more functional neuroplasticity, which I know we'll talk about. And what I like about what you said about reduced nerve transduction speed is that the modifications we can make to gait speed and balance and dual task ability, which we'll talk about later, is primarily through these functional changes. And the structure may not change, but the function, the neuromuscular adaptation, for example, the speed of a nerve transmission can change. And we can actually affect that relatively quickly with the right programming, right?
Right. And super important when it comes to recoverability from balance disturbance.
Yes,
so
indeed.
Super important. And obviously we have people who have disease processes like diabetes, diabetic neuropathy, where sensation is lost. And that is certainly a strong predictor for bad outcomes. So we want as best we can to manage and prevent those issues through a good physical activity program combined with other positive lifestyle behaviors. And previous musculoskeletal injuries, you know, Ryan, if you could speak a little bit to how the body remembers insults that has happened to it. It remembers.
Well, last time I've done a couple dissections, I still can't find trauma in those tissues. However, a lot of what people are talking about of trauma stored in the body or muscle memory, it's all neural adaptations. It's all the somatosensory cortex, maybe some interaction with the deeper brain structures like the amygdala and brainstem. But really, there are so many studies now demonstrating the neural relationship of pain and its mechanistic adaptations in the brain. As it relates to musculoskeletal injury, Dr. Chris Powers, who is one of the most famous biomechanists and physical therapists at USC, mostly deals with athletes, is very interested in the neural adaptation of ACL tear and rehab. So many people are not just focusing on the physical mechanics of it, but the ACL tear likely happened from a neurally based external goal, right? That created this dissociation or a lack of negotiation of the body and brain. And then the rehab, therefore, because of the injury creating some sort of deficit or a neuroplastic change, therefore, the rehab needs to consist of some sort of neural inputs as well. Dr. Beth Fisher at USC, who's also an amazing physical therapist researcher, who's one of the first to publish on the benefits of Parkinson's and the effects of exercise on the brain in individuals with Parkinson's, is now showing that soft tissue and joint manipulations create neuroplastic changes in the brain according to functional neuroimaging. So this stuff is complex. We're just, the past few years are really starting to shed a light on what we attributed to be primarily muscular or physical, and is now primarily, or at least partially, neural.
Very good. Okay, so the other system that I wanted to touch on that plays a very big role in this body-brain integration, the sensory motor integration process, and balance and fall risk and gait, is the vestibular system. So tomorrow, I'm doing a whole session on vestibular balance training. And these are a couple of little elements that come out of that. Clearly plays a very, very important role in connecting all three of these balance control mechanisms and their inputs to the central nervous system to result in optimal motor outputs. So I want to just briefly talk about the vestibular system, the structure of the vestibular system, and ultimately how it functions and how it can kind of go awry a little bit, unfortunately, as we get older, which clearly, again, then will have an effect on balance, will have an effect on gait, and may even have cognitive effects as well, and can be benefited by cognition exercises and training as well. So let's talk briefly about the vestibular system. So inner ear, we can see here, we've got our three semicircular canals up at the top. We also have kind of two more bulbous structures, the utricle and the sacculae. And then we have the snail looking thing, which is our cochlea, which again, about hearing. All of these sensory systems are closely integrated with each other, both in function and in some cases in location, such as hearing and vestibular function. And what's interesting is these structures are based on movement of fluid or more like a gel-like substance within them that respond to acceleration, deceleration, changing of direction, and that results in fluid moving through these structures. The structures have little hairs in them, little cilia. So we see here kinocilium.
Not to be confused with cilia from FAI, different.
Correct. Yes, this is not cilia. This is cilia. So the cilia move in response to the motion of the body and how that acceleration and deceleration of the body moves the fluid within these structures. So it's a very, very complex and what would we call it? A very sensitive process or structure that allows the vestibular system to work effectively. We need to have enough of that cilia to be able to move and respond to motion within the body. We need the motion in the body to actually move that fluid correctly and effectively. And if there's any breakdown in there, we can have some issues. Now, we also notice above the kinocilium, we have otoconia, and that's on the lower right side of the illustration here, this little kind of blow up of the illustration. And otoconia, that's basically just calcium calcifications or calcifications within the inner ear structure. They're meant to help to stabilize the inner ear. So you really do have little rocks or little crystals within your vestibular system. So when my mom used to say after I do something stupid, what, do you have rocks in your head? Now I know that I do have rocks in my head, and those rocks in my head help my vestibular system function effectively and allow my brain to know what directions I'm moving in, where I'm sensing accelerations and decelerations, all through this very detailed and complex microstructure. So moving on.
Well, I would want to say one thing, Chris. If I was to name a child of mine, perhaps in the future, after one of these structures, you know, Krista would be the most obvious, but I would love to name my child Samuel. I think that's pretty, it's like Samuel, but you know what I mean? Right. Would you? Right. Okay, let's move on.
Yeah, but the unfortunate thing is the nickname would be Sack. So, hey.
All right, I'll stick with Krista.
That's not good. Stick with and they can be Chris. Yeah. Okay, so let's talk about the age-related changes in the vestibular system. So first of all, similar to many people lose hair on the top of their head as they get older, we also lose the kinocilia inside of the vestibular system. So those kinocilia begin to, whether it's due to too much motion over time, they break off like a branch or a twig when the wind is blowing, or they lose their anchoring to the tissue below and they kind of float out and fall off. So we start losing that cilia. And the more loss of cilia we have, the less sensitivity we have of the system. Only an intact cilia that's moving in response to motion will then result in a neural signal to inform the central nervous system of what's going on. So the more hair we lose inside the vestibular system, the less sensitive the system gets, the more motion needs to occur in order for the central nervous system to be informed of it. In other words, a light breeze is probably not going to activate those vestibular receptors. We need a stronger wind or more acceleration and deceleration, which could lead to a lack of sensitivity simply with controlling standing postural sway. You notice when you watch older adults, you're having a conversation with them and they're standing there, we can actually observe sway occurring. If you have actually seen that, go ahead and just kind of give a quick little like thumbs up, or yeah, I've seen somebody, an older person who, when I'm talking to that person, they're just sort of like oscillating in space.
Or when you're drinking,
Well, that happens to us when we're drinking, right, Ryan? But that's just very likely due to a lack of sensitivity in the vestibular system as a result of this aging process. And you can think, okay, well, if a person doesn't respond to postural, it takes them more time to respond to just this basic postural control mechanisms, how difficult is it going to be for them to respond to something like a trip, a stumble, that could ultimately end up leading to a fall? So these have real world negative effect on potentially bad outcomes. Additionally, the otoconia, the otoliths that we see at the top here of this diagram, they can dislodge. It's almost like, you know, you've got a little bit of a popcorn ceiling. And in California, occasionally we have popcorn ceilings are out, by the way. Okay. My wife,
I actually don't know what you're talking about.
No, popcorn ceiling.
I have no idea what you're talking
about. It's like a textured ceiling. Okay.
Okay.
I didn't know it was big back in the 70s, Ryan. Before
millennials. What can I say? All I know is Instagram. Is Instagram a ceiling?
And if you get like a shake in the foundation, let's say in California, we get a little bit of a rumble, some of those popcorn pieces start falling off of the ceiling. Okay, well, that can also happen within the vestibular system. Some of those calcium crystals begin to float around in the gel, in the fluid, and when they start contacting the cilia, well, it bumps the cilia in one direction or another. So the cilia tells the brain that we're moving, when in fact it's really the disturbance of these otoconia, those otoliths, that then inform the body about movement that's not really occurring and can lead to kind of this sensation of motion, what we would call benign paroxysmal vertigo, where someone sort of gets dizzy even when movement is not occurring. So again, because these structures are so complex and these ultrastructures need to maintain their integrity for proper function, as we get older and they start to lose function, we start to have these real issues that will occur. And there's an estimation that over the age of 65, over 30% of older adults have detectable dysfunction within their vestibular system. And that clearly can then lead to downstream effects of balance issues, potential falls, and just not being able to control one's motor responses during situations such as walking, balancing, sport, things of that nature.
So one statistic I've heard is that every decade, I think starting at age 50, the vestibular system decreases by 10%. Is that right?
Yeah.
I think I heard that from you, right?
It's other studies have indicated 40% per decade.
Oh,
so
wow.
When you think about progressing that from 60 on to 90, then we're pretty much in a very bad situation.
And that's not considering neurological deficit or conditions or traumatic brain injuries, or concussions.
Correct.
We'll talk about later, but
right.
The more older adults I talk to and really well screen, many of them have had concussions that contribute to vestibular. Like, oh, I just hit my head, it's normal. I'm like, nope. And they never did a screen. They never did vestibular rehab or training. So it can be a big problem.
Right. No question that concussions have, many of the rehabilitation protocols associated with concussions are very consistent with rehabilitation protocols for older adults with vertigo, because the system is being affected in a different way, but it's still needing to respond and heal from whatever the insult happened to be.
Yes, most definitely.
All right, this looks like you, my man.
Indeed. So I actually was going to put in a slide about hearing loss, but wanted to be more fully encompassing of just sensory impairments in general. So one of the first things I do with my patients that I work with, I don't, of course, after I do an intake, there's two things I'll do. I'll ask them about hearing aids. I'll check when they last got their hearing aids. I want them to have the most up-to-date ones. Technology is amazing. It's a multi-billion-dollar industry. Many people have hearing aids that are many years old, don't have them functioning at all, just never got it done, didn't think it was important. And then I clean their glasses because the lack of visual input and the lack of hearing-based input can significantly increase the speed in which an individual can experience cognitive decline. So I asked them about their hearing aids. I asked them about their glasses, when they last had a visual exam, if they've had a vestibular exam. And most ENT doctors that work in geriatrics can provide those services. I'll also ask them if they have things like sleep apnea, because that can contribute to cognitive decline as well, significantly in fact. And so I'm just checking to make sure their hearing aids, their glasses, their CPAP machine, if applicable, is all up to date, working and being utilized. Usually it's not, because they or their caregivers or care partners feel that it's not something that needs to be worried about, or there's no advancements of technology. But the reason it's important is because they can significantly contribute to brain structure and functional changes, depression, social isolation, reduced activity. We have so many patients, and once again, it's a chicken and the egg conversation, that have hearing loss with depression, with cognitive decline, and they think it's normal, right? But they haven't had their hearing changed in 8 weeks or 8 years. They're not exercising, they're not sleeping well. And a lot of that could be prevented or ameliorated. Overall, that contributes to impaired cognitive functioning and can reduce quality of life. Once that etiology occurs in parallel with aging, vascular disease, et cetera, that's a recipe for disaster. So one, working with other medical professionals in ENT, neuro-ophthalmology, geriatricians, you can actually create this comprehensive environment in which you're trying to address healthy aging in multiple ways. And as well as because we're looking at the common etiologies of aging and vascular disease, we know exercise can help with that. So with the drills and programming that we'll show you today, combined with just good exercising programming in general, and having a common sense medical fitness practice and looking for these details, you can make a significant change and deliver a much greater value to your clients.
I agree. Ryan, can I make a comment there as well?
You may.
So just as we mentioned earlier, how important assessment is to drive program design, and it's not just something we should do because we've been trained to do so. Just basic medical history and lifestyle history intake information.
Oh my gosh.
Such as, when was the last time that you had your vision prescription checked? When was the last time you went and had your hearing checked? That information is so important because it can inform us about what might be going on with our particular client and how things that they can take charge of and be proactively engaged in outside of the time working with us can benefit their overall function. So recognize that basic intake where you're going through your health history, it should be looked at, especially with older adults, no question about it. You really need to look at it carefully and look at the connections between what you're seeing on assessment or what you're seeing with their current movement skills during training sessions and how that connects to kind of what their situation is from a health history perspective. Ryan, do you agree with that?
Yes, and clean their glasses.
Yeah, absolutely. No
Once
doubt.
you have enough rapport, it's a little awkward. Like, good to meet you. You just take their glasses and clean them. But
the other element that I wanted to touch on too, Ryan, is just, the fact that so many older adults still kind of have in their mind that things that happen to them and changes that they may be seeing or perceiving or losses of function, they attribute to, well, this is just part of the deal.
Right.
This is part of getting older.
it's a negative age belief.
Yeah, and this just culture of ageism in our country and really around the world does not help at all because people are just kind of messaged to accept the fact that you're getting older and things are going to be rough. Yeah, there are things that will change. No matter how well we program for a person, we will probably see a loss of physiological function over time. However, there's always the ability to adapt or assimilate to those changes and still have an incredibly high quality of life and not just accept that, well, this is just part of it and it's another thing that I just have to deal with as a part of getting older. Getting older sucks. And
That's
unfortunately, that perception can really result in us maybe not being fully informed about the things our clients are dealing with because they might not even think that it's worth mentioning. But for us, if we understand kind of these negative perceptions that they have, it helps us kind of battle those and become anti-ageist pioneers.
And we'll talk about assessment and we'll even introduce a couple questionnaires. But one such questionnaire is the expectations regarding aging questionnaire, which actually allows you to assess what people believe, positive or negative age beliefs in various categories: spiritual, musculoskeletal, cognitive, and psychological. And you can actually assess what people actually believe about aging and themselves based on the experiences around them, their own experiences. And at least for cognitive impairments, what research has shown using this questionnaire is that people with positive age beliefs have a reduced chance of developing dementia of 50% when compared to their negative age belief counterparts. So just believe, and we're not talking about belief in like the self-development, Tony Robbins, Joe Dispenza, just believe in your neurons change type of thing. You know, we're not going to get into that, but we are talking about that. What I appreciate about the functional aging model is that it includes things like self-efficacy, right? And so as belief drives behavior, it's important for us to assess things like that, whether it's in an official way using a questionnaire or just in a qualitative discussion-based format. I think we're almost done.
Do we want to take a quick break, Ryan?
We're going to have a break in maybe 2 slides, so let's wrap this up here.
Okay, perfect. Sounds good. Sounds good. Okay, so ultimately what it comes down to, and this again will be touched on to a greater degree in my session tomorrow, we can improve the function of the vestibular system and its integration with our other sensory inputs, somatosensory and particularly visual. There's a lot of studies that have supported the effectiveness of vestibular rehabilitation training called VRT. And, you know, again, athletes with vertigo or athletes with concussions and older adults with vertigo oftentimes are effectively treated via the same sorts of interventions, just perhaps progressed versus regressed when we're talking about athletes versus older adults. And when we get to discussing tomorrow, we'll also talk about different types of vestibular rehabilitation training, habituation, adaptation, substitution, either exposing people to things that cause problems and getting them used to it, or providing different movement strategies that are meant to kind of rewire this system. And we're also finding that later today, we'll talk about technology as it relates to gait and cognitive training and balance training. We also use virtual reality quite a bit as an element specifically for vestibular retraining as well, because you can create a simulated environment that is really, really robust and highly enhanced that can provide for the right person at the right time, not overloading them with too much challenge, but provide them a really robust vestibular rehabilitation experience, even if they're just sitting at home not doing anything else. Okay, moving on.
All right.
All right, so ultimately, what really it comes down to, this mechanism of adaptation, the way that sensory motor integration gets better is through finding ways to stimulate and improve the input from our receptor or from our balance control mechanism systems. So if we can enhance the somatosensory, the visual, and the vestibular input coming into the central nervous system, it has more information to work from, and therefore will create more optimal motor responses. And what does that really mean? Well,
I don't know, maybe neuroplasticity?
That sounds like neuroplasticity. A way that the brain and the central nervous system is able to function more effectively can be directly related to the quality of the inputs coming in that can relate directly to the effectiveness of how you stimulate those systems through your training. So we can really provide that with our programming. Okay, we're going to briefly also talk about gait. This is before our break. So we have to recognize that gait, or this process of ambulation, whether it's walking, running, playing sports where there's constant kind of changes of direction, gait is a complex process, both physiologically and neurologically. There's a lot going on physiologically and just with different systems of the body and different control mechanisms. And neurologically, we have to be dealing with the situation we're currently in and anticipating how things need to change in order to effectively respond to whatever we're ambulating toward or about to experience. So we have 4 primary kind of phases of gait that I want to briefly talk about. One is where the leg is unweighted, okay, where it's unweighted, the leg and the foot is off the ground. That consists of what's called the swing phase, where the leg in an open chain situation is swinging through prior to its next period of foot strike, prior to it striking the ground. Now, what we really need in order for the swing phase to effectively be produced both in a distance and amplitude standpoint is good joint mobility. If your hip, your ankle are not flexible enough, then your swing phase becomes more of a shuffle phase because we simply do not have the mobility in those two important joint structures to allow for us to be able to get adequate stride length and stride amplitude. Okay, additionally, we'll have one leg that's in contact with the ground as the other leg is swinging. That is the stance phase of gait. In order for that stance phase to be effective, we need to have enough muscle strength and stability of the joints of the lower body that help us accommodate the ground reaction force, the actual weight of the body on the ground, and be able to allow us to stay what we would consider to be balanced during gait. So we need muscle strength, muscle power, and joint stability to effectively be able to bear weight during the stance phase of gait. Then we need to effectively be able to produce force in a concentric, from a concentric perspective during push-off so that we can have enough force production so we can have effective gait. We can produce adequate gait speed. So we're not just going almost in slow motion. So we need strength and power in order for push-off and therefore gait speed to be effective. And we also need great eccentric control where our body is responding to the ground reaction forces upon foot strike so that we just don't crumble and our joint integrity isn't compromised and we're able to still walk with an excellent upright posture. So we've got a lot of physiology going on specific to gait. And why is it important, Ryan? Well,
oh, are you asking? Oh, you're telling me to go to the next slide. Okay, sorry. I'm like, I don't know.
There we go. That's a lead.
Luckily, we have a doctor here to tell.
I don't want to say next slide, please. And ultimately, guys, gait is so important because walking speed, the ability for us to ambulate with adequate speed, has incredible predictive correlative effects on morbidity, disease, and mortality.
And that's physical and cognitive mortality.
Physical and cognitive, absolutely. So there was a study done back in 2011, and researchers like Ryan and I, you can tell we have no personalities whatsoever. We write in boring ways. We talk in we're boring people. And
we're like the adults from Charlie Brown,
yeah.
Right? Wah, wah, wah.
And you never read a research article. It's kind of fun. Well, I urge you, go to British Medical Journal 2011, their Christmas edition. Every year they actually let.
Oh, it's the Christmas edition. It's almost like, wow. That's very
like the holiday edition, a little present from British Medical Journal to people during the holidays. And they actually write still research articles, but in kind of a fun way. Back in 2011, these authors did a study on not just gait speed, but how fast does the Grim Reaper walk? So they looked at a meta-analysis of many, many different studies and determined that the threshold, again, we're talking about these thresholds from aging curves, the threshold of gait speed, if you are below 0.8 meters per second, that is just under 2 miles an hour. If a person is ambulating slower than 0.8 meters per second or just under 2 miles an hour, that's the speed that the Grim Reaper walks. It greatly increases the risk of mortality if somebody is walking at that speed. So recognizing that gait speed is really going to be determined by all these physiological inputs. We have to be strong. We have to have muscle power. We have to have muscle strength. We have to have concentric production, eccentric control. We have to have balance capabilities, and we have to have joint mobility to allow for stride, the swing phase to effectively work. It just really quantifies the importance of gait as a surrogate measure to kind of show us overall function. There's another study done that I present here. You guys will get these PDFs, so you'll be able to actually see these articles, at least read their abstracts, and then you can dig in a little bit deeper with a PubMed or a Google Scholar search to get the primary source. study, again, looking at the correlation between a person being able to perform a lot of walking in a short period of time. It's called a corridor walk. It's basically a 400-meter corridor. And the fact that people that walk a longer distance in a shorter period of time have a lower incidence of both mortality and other morbidities, such as cardiovascular disease, mobility limitation, and other forms of disability. So really this idea of gait and gait speed and the ability for our body and our brain to work well together to produce adequate gait speed, it is so clinically significant that there have been physical therapists and nurses and other clinical professionals who have pretty much said this is an essential parameter that should be measured during every clinical visit that a patient, an older patient, makes to their clinical professionals. Walking speed, they believe, truly is a diagnostic sixth vital sign. Just as important as measuring somebody's blood pressure, just as important as measuring somebody's temperature, checking out gait speed and ensuring that their gait speed is above this threshold of 0.8 meters per second has such a strong correlation to morbidity and mortality outcomes. That is an essential thing for us to measure and be aware of, and also an essential thing for us to develop our programming in order to try to impact. And it's not just saying, okay, Mrs. Jones, go ahead out and let's practice walking fast. We need to come at it from a very integrated perspective, or focusing on specific performance parameters and introducing cognitive challenge, because again, walking is a highly demanding cognitive activity. So we cannot ignore the cognitive responsibility of walking, and we have to train that as well. Ryan, before our break, anything you want to add there?
Well, we will talk about gait speed. Certainly, gait speed has also been linked to the risk of dementia. It's been linked to greater propensity to experience more cognitive decline, especially in the context of neurological conditions like Parkinson's and MS. It becomes even more important. Later, we'll talk about dual task ability during gait, because most of the time we're not just walking as fast as possible without thinking about anything. Typically in the clinic and during these assessments, the single goal is to walk. But in reality, it's more ecologically valid if our environment is our ecology and the validity is the transfer from what we're looking at in the gym or the clinic to the real world. What happens is gait is utilized as a measure of an external, or sorry, as a medium for an external goal, right? So I am usually walking for the purpose of going somewhere. Even if it's leisurely or exercise based, I am going somewhere. It's goal-oriented behavior. So with that said, and with complex environments, that gait and cognitive stimuli and cognitive distractions really is almost an enhanced way to look at this vital sign. So it's a way, and you might call it dual task performance. Maybe that's the seventh vital sign, right? And so we will talk about that at length later. But for now, we have a break de baño. We're going to allow everyone to go to the restroom. What do you guys say? 5 minutes, 10 minutes? What do we think? What do you think, Chris?
I think let's go 10 minutes.
10 minutes? Sounds good.
Yeah, we'll try to address this question and answer thing too. We might just have to use the chat.
Yes, let's use the chat. I'm not sure why Q&A is not available. I've never seen that. But I will try to figure that out over our break. Hopefully we can come back and have a nice little Q&A section. If you are experiencing Zoom fatigue, a quick neural tip, do something called cupping. No, not the massage technique. You actually take your hands like cups, you cover your eyes, and you take deep breaths. You completely block out any visual input. Take some deep breathing, calm down the nervous system. That will allow you to come back, feel refreshed. Eye strain, even if it's not neural, eye strain can affect the integration and the integration of information. So we don't want information overload. There can be visual eye strain. So cup your eyes for a couple minutes, take deep breaths. You can even do it with your ears because we're using a lot of auditory and visual attention systems. So nice little tip for you. Do not bring your Zoom into the bathroom with you. There's an SNL skit where they do that. Do not do it. And if you do it, you know, make sure the video's off. or if, we will be recording that, we can sell it for.
Ryan,
yes.
put yourself on mute.
Okay, sorry. All right, we'll be back in 8 minutes-ish.
Gait has been slow for many years. I guess they are the exceptions. That could be true. It's also possible that you're observing their gait in a certain context, but if you actually were to do a straight line ambulation gait, a walking speed or a gait speed test, they might actually walk faster than the 0.8 meters per second. So they might be kind of getting close to that threshold, but unless you truly do a walking speed test, best way to do it, 10-meter course. So you basically about 33 feet or so, start, finish, and you have a 2-meter acceleration and a 2-meter deceleration period. So you start the clock when they get to the 2-meter mark. You end the clock when they get to the 8-meter mark. They start at 0 and they end at 10. And then you determine in that middle 6 meters how fast they're walking. So basically you take the time or you take the 6 meters and divide it by the number of seconds, and it will give you a measure in meters per second. And it's possible that they might be over 0.8, or if they are below 0.8, they might be doing well now, but they might not be doing so well in the future. Another question, walking poles for assistance count, or do you need to walk without holding anything? There are tests that, walking speed assessment tests that are normalized and have normative values for people using assistive devices. Again, it appears as though the 0.8 meters per second threshold, whether with or without an assistive device, is pretty much our predictive value there. And a question about cannabis for post-concussion.
I want to, it's a touchy topic, but I will say that consult your doctor. It depends on what. THC as a compound, CBD separately can be helpful in certain instances. More research is needed, asterisk, but THC can not always be neuroprotective. Usually it actually can accelerate a reversal of neurogenesis and its ability. It can have some significant impacts in terms of sleep quality, not in a good way. However, CBD or THC, when used under the supervision of a medical doctor, may be helpful for certain symptoms. But there's a lot of confusion over this, especially in the older adult community that are using the wrong ratio or way too much THC, and it's causing all sorts of other health issues. For concussion, I wouldn't use THC as the first line of defense. Exercise, cognitive training, physical therapy, sleep hygiene, mindfulness. There's so many other first lines of defense before going that way. Supplementation with omega-3s. Some are more positive. I can be a fan under the right conditions, but because of the mainstream tendency to take these things, misunderstand them, and misapply them, I usually go, let's not talk about that. Yeah.
Very good. All
Okay.
right, let's jump into neuroscience of brains and balance.
Indeed we shall. And I want to emphasize that what I'm about to show you is immensely graphic, meaning there's a lot of graphics, but there are a lot of concepts in here. And I want to explain that we're looking for concepts and takeaways versus the complexity of memorizing everything I'm about to show you. So they are cognitively complex. There's a lot of cognitive load in some of the charts I'm going to show you, but most of it is to gain an appreciation for the complexity and integration of the brain as it relates to the systems associated with balance and gait. So without ado, let's talk about dual tasking, multitasking, and falls and gait. So what is dual tasking? Dual tasking is two concurrent yet separate tasks, for example, physical and cognitive, i.e. walking while talking. Multitasking is doing more than 2 to 3 things at one time and sounds like the same thing, but isn't, because multitasking can use 2 tasks through the, say, visual field at the same time. And there's a lot of confusion about multitasking versus task switching. Sometimes all three of those things are used interchangeably, but for the purpose of this webinar, we'll be more specific to dual tasking. So how does this relate to falls and gait? I was carrying some groceries, then I fell. That is a motor dual task, right? And actually there's some cognitive in there too. Anything you're doing with your hands where they are loaded, they are manipulating their bodies around the environment during gait, that's a motor dual task less than a cognitive dual task. A cognitive motor dual task would be I was having a conversation when I fell. I wasn't paying attention. So it could be paying attention to the environment. We'll talk about brain networks later and how there's this sort of more mind-wandering brain network versus the attentional brain network. I was looking at my smartphone. I will admit, as a 28-year-old non-older adult, that one of my daily fears is rolling my ankle and falling while I'm looking at my phone. I have that fear. Chris, do you have that fear?
Not so much, but I do kind of get stressed out when I'm walking downstairs and I'm on my phone. So
yes, especially.
Totally ensure that I am fully engaged in downstairs walking activities without any other distractor.
That's right. Next thing I knew, I was on the ground, almost like people don't know how they fell on the ground, right? Chris, is there anything you want to say about dual tasking and falls and gait from what you see from your perspective with your clients and stories around that?
Yeah, sure. So, I've been running fall prevention exercise programs in San Francisco since 2007. And actually, we even did pilot testing all the way back to 2005. And part of that includes intake. We've been talking about medical history, and I do a falls intake questionnaire to get information about what the circumstances were for people having accidental falls. And there are two primary things that come out of that. Number one, I've never had anybody tell me that they have fallen when they were just standing around doing nothing. Falls generally are in response to movement, whether it's ambulation or whether it's something like a reaching task, but it always involves movement. So therefore, we should train balance and falls risk reduction through movement. Just standing on one leg is not good enough. And then the second element that we typically get out of it is that almost everybody talks about the way in which they were distracted when they had their fall. The majority, I'd say well over 50% of our participants fell while dual tasking or multitasking. And they attribute it very much to a lack of attention and awareness and being focused on the task at hand. And, but there could be also underlying physiological deficits that led them not to be able to recover effectively when that balance challenge did occur.
Correct. And, for the patients I work with, it is a majority of them have come to me and they explain these conditions in which they fall, not exclusively, but much of the time due to a dual task failure. And sure enough, when I assess them for dual tasking, which we will go over how to do today, they might do a timed up and go or a gait speed test very well, when that's their singular focus. And then I introduce this dual task condition, and it's 2 to 3 times, maybe more, slower than when they did the single condition. So dual task ability, it's a complex cognitive and neurophysiological phenomena, but it really relies upon what's called divided attention, which is an ability that declines with age normally, and quite significantly, especially if not trained, and even more significantly in those who have neurological impairments or deficits. So divided attention, or in this context, dual tasking, is a very important thing to train and is often missing from our exercise programs. So what precedes falls? Well, typically it's the prefrontal cortex, perhaps, right? And what's interesting about the prefrontal cortex, if you take your hand, and don't do this hard, and make sure you wash your hands because of coronavirus, put it on the front of your forehead, okay? Right underneath. I told you not to do it hard, Chris. Now you gave yourself a concussion. Right underneath your forehead is the prefrontal cortex. It's the 1/3, not under your hand, but the 1/3 front half of your brain is what makes us uniquely human. That's where your prefrontal cortex is. It's also lit up when you're doing dual tasking. It's also called Brodmann's area 10. It's the frontopolar aspect of the brain. The prefrontal cortex is responsible for a wide variety of functions. Overall, they're called executive functions, and it's involved in controlling attention, divided attention, impulse control, organizing, planning. The frontal lobe as a whole, not just the prefrontal, but the posterior aspect of the frontal lobe, is responsible for motor planning and motor initiation, and also the control of motoric inhibition. And then divided attention and other executive functions decline with age. So do falls happen when we are focused or when we are distracted? We already talked about that, and we could probably agree a majority of the time it happens under distractibility. Therefore, it behooves us to distract our clients. And we'll talk about how to do that in a systematic fashion. Now, it makes sense that we are supposed to negotiate cognitive and physical tasks together because theoretically, that is how we evolved. There's this model called the adaptive capacity model by a colleague of ours named Dr. David Reichland. If you look at, I think, the past 2 or 3 issues of Scientific American, it's about exercise in the brain. He wrote that article with his colleague Gene Alexander, who's a neuroimager, and they're brilliant in their research. I'm a big fan of their research. He is like the Indiana Jones of evolutionary neurobiology. He's awesome. And he's also doing research on combining cognitive and physical training to improve cognition in older adults. And one of the models that he presents is this evolutionary neurobiological rationale linking movement and thinking. So we have our sensory and attention systems, not just the eye, but the ears, the vestibular systems, the thermal and touch receptors. We have our motor control and learning systems for manipulating objects. We have the spatial and memory and navigation system, which is usually linked in literature to the hippocampus, which we'll talk about. We have executive functioning demands. Remember, we talked about executive functioning in the context of the prefrontal cortex. Slap your forehead. Problem solving, cognitive flexibility, which is adapting to new and unexpected circumstances, which I would say a lot of where falls happen is there. You didn't expect something to be there. You didn't expect that car to stop, screech out in front of you. You didn't expect something to happen. And the failure to flexibly adapt may cause a motoric inhibition failure and you fall perhaps. Planning, motor planning. I'm going to go this direction versus that direction, whereas the one I picked was probably not as safe. Or if I picked the more unsafe direction or path, I didn't plan effectively to step over an object in a specific way, like a curb, right? Then we have speed manipulation. So we can go slower speeds to faster speeds. So the processing speed requirement, this is both physical and neural. So we're talking about gait speed and we're talking about reaction time. So it's, it's not just moving fast. That's the important thing. It's moving slowly with control, which is why we love corrective exercise, gait rehabilitation strategies and training strategies. We like slower, more resistance-based exercises to work on eccentric control that mimic gait, like lunges or loaded carries. We like things like Tai Chi, but we also like the power training, the gait speed training. We need all of that. And ideally, we're introducing that, but then ideally on top of that, we're introducing cognitive demands. And I like to show this to justify that. Chris, is there anything else you want to say about this?
No, I mean, it's pretty clear that, in order to be successful, adapt or die, right? So it's either you have to have a purpose. Like you said, walking and movement is oftentimes purposeful, and we can trace
goal-oriented
all the way back.
Right.
All the way back to the purposeful reasons for movement to allow someone to provide for themselves and their families, their communities.
And in this goal orientation and having this purpose, it's one of the biggest criticisms of general aerobic exercise in terms of improving brain health. So there's been a lot of debate between the research communities of, is aerobic exercise alone enough to enhance brain health? And there's debate is revealing some light on the fact, well, maybe not, especially if we're going to significantly improve executive functioning. What is demonstrating to be more significant is multi-domain programs, aerobic, resistance, coordinative, and skill-based modalities that are going to significantly make better changes on brain health, including that of executive functioning. And what's interesting about this is that if we usually fall under purposeful movement that we fail to negotiate, then what would it be like to make our exercise techniques and our exercise in general purposeful, to have a goal? And that's what I want everyone to take away from this at the least. Now, to talk about some of the brain regions that I think are important to understand in relationship to, let me get my pointer, in relationship to falls. So we have the prefrontal cortex, which is the front right here. We have the rest of the frontal lobe, and that part of the brain is responsible for movement initiation and planning, among other things. Between the prefrontal and the parietal is that sensory motor strip, that somatosensory cortex. The parietal lobe integrates sensory stimuli. The occipital lobe integrates visual input. The temporal lobes have to do with navigation. Deeper to the medial temporal lobes is the hippocampus, which we'll review, and deeper into the brain, even more so, areas like the amygdala. The medial temporal lobes have been linked to physical activity and exercise. So when you hear about the hippocampus growing in response to exercise, or the medial temporal lobes being smaller in those with more sedentary behavior, that's what this is responsible for. The cerebellum responsible for coordination of movement, and of course the brainstem here responsible for reflexive and non-conscious brain functions. I'm of course being overly simplistic here, but I think it's a nice little primer to the brain. Let's briefly discuss that hippocampus. So the hippocampus is in those temporal lobes. It's a bit deeper. You could say it's part of the more primitive regions of the brain, even though I don't like to use that primitive association. Its decline is attributed to memory-related issues. It also increases in size with aerobic exercise and general physical activity, and seems to have this interesting relationship with the lower extremities, whereby there are some studies correlating locomotion and rhythmic stepping with hippocampal volume and function. So what we're going to talk about in the slides to come is how gait and balance behavior might be linked to brain structure, function, and cognition. So specifically, for the purpose of assessment in the etiology of disease, there's two really common neurodegenerative diseases: Alzheimer's disease and Parkinson's disease. Okay, they're not exclusive, but they're probably the most common ones that you'll hear about and take up a majority of those statistics. So when people with preclinical Alzheimer's disease, meaning they don't have it quite yet, or at least we have an appreciation that individuals with Alzheimer's disease or individuals who might have a risk for Alzheimer's disease might have an altered pathway that I'm about to describe here. Their prefrontal cortex function decreases, therefore their attentional control of gait decreases. So attentional control of gait, if we were to assess and train that, maybe that has a relationship with the risk and perhaps or possible delay of Alzheimer's disease. For preclinical Parkinson's disease, basal ganglia function usually is associated with the etiology of Parkinson's, and the basal ganglia is deeper to the brain. It's where automatic movements are stored. So the reason individuals with Parkinson's have issues with gait, which used to be automatic, is because the area of the brain, the basal ganglia, which stores automatic functions, is dysregulated in its function of dopamine. Therefore, things that used to be automatic, like gait, are more troublesome. And they have more dual tasking issues because they couldn't just do gait like you can and not need to focus on it. They need to focus on gait and a task. So dual tasking can be forcing them to re-automate gait because they're distracted. And there's a lot of interesting research in neurorehabilitation and physical therapy practices doing that. So therefore, there's an opportunity for us, whether it's preclinical or individuals with Parkinson's or Alzheimer's, to be able to look at this. Of course, age, gender, processing speed, cognitive reserve, and stress play a role. But most importantly, in the way it's all related is in this dual task paradigm. We're going to talk about how to assess it and what else goes into it. So complicated slide, but I think it's very interesting to look at. It's not exclusive to these brain regions either, but how it has these unique pathways and how it might affect cognition in relation to gait. Chris, is there anything you want to say about that?
Well, I think that's really done well, showing that different pathways can have effects on the same task. So well done.
Thank you. All right, so we're not going to spend too much time here, but this is from a paper called Gait Variability in People with Neurological Disorders. And it's a systematic review and meta-analysis. So they're looking at a bunch of different papers and they're trying to reference how gait can be affected by all these neurological conditions. So we're not going to go over every single one of these things, but we see the different regions of the brain, the cerebral cortex, the limbic system, which has the amygdala, the hippocampus. We have these motor neurons. We have the myelin that goes around the motor neuron to facilitate the speed of the signal. We have the basal ganglia, and we have the cerebellum, okay? So there's different conditions like Parkinson's, Huntington's, cerebellar ataxia, which can be comorbid with Parkinson's or concussion, Alzheimer's disease. This is just to gain an appreciation that these different diseases have a relationship with gait. So taking that conversation further, Chris, of gait as a vital sign, yes, we need to have the diagnostics of neuroimaging and cognitive testing and neurological exams. And typically among those exams are the assessment of gait. For our interest, it's less likely that you're working with these individuals that have these conditions. It's more likely they're working with physical therapists. And if they're not, they should be. But I think for us, we're looking at the prevention of these conditions and also the opportunity to work hand in hand with neurological physical therapists and neurologists if you have the techniques in which to do so. I won't say that this webinar will give you those techniques, but it will introduce you to concepts that could be a platform for learning that and maybe having a more profound medical fitness practice. Mm-hmm. This is from a paper called Regional Cerebral Glucose Metabolism and Gait Speed in Healthy Community Dwelling Older Women. And this is talking about how cerebral glucose metabolism is basically how the brain metabolizes brain activity and glucose, in which it's a very glucose hungry organ. We're not going to go over these brain regions, but this paper was essentially relating glucose metabolism in the brain to gait speed. And I think that's really important to understand that as we're talking about gait speed, Chris, there are these neurophysiological underpinnings such as glucose metabolism. It is generally thought that in most brain regions, as we age, our metabolism is less efficient. Well, guess what makes it more efficient, both directly and indirectly? Exercise, sleep hygiene, general lifestyle medicine, preventative care, but also being able to train these functions specifically. How can we train more efficient cerebral glucose metabolism? In addition to having a multi-domain exercise program, coordination training, resistance training, aerobic training, and multiple types thereof, if we want to look at the prefrontal cortex, which we'll highlight right here, let's theorize that we wanted more efficient cerebral glucose metabolism in that area because we've talked about its importance in its relationship to gait and balance. Well, we would want to push neural resources and stress that area in a good way via things like dual task training to be able to make that area of the brain more efficient. So because older adults, when compared to younger adults, don't have as much glucose efficiency during certain cognitive or dual tasks in that area of the prefrontal cortex, training can help that change. We can make people more efficient in terms of functional brain activity in that region, in terms of cerebral glucose metabolism in that region, and eventually with enough lifestyle modification, positive stressors over time, stresses, and enough training, we can actually perhaps see over periods of weeks and months, volumetric changes in the brain, whether that is stopping it from decreasing in size or actually increasing it in size, as shown by volumetric MRIs. Oh my gosh, it gets more complicated, right? We're not going to point this out too specifically here, but I am going to give a shout out as to what we talked about before and where it lives on this chart. So this is from the paper Neurophysiology of Gait, from the spinal cord to the frontal lobe. You know that song, From the Windows to the Walls? It's like that, but with spinal cord and frontal lobe. Anyway, so we have the body schema, which we talked about earlier in Chris's section: visual sensation, vestibular sensation, somatosensation. See how the visual cortex plays a role in the parietal cortex, which integrates sensory information. And it also has a bidirectional relationship with the vestibular cortex. So when we talk about vestibular stimuli, we're also talking about vestibular nuclei in the brain. And so for every adaptation of vestibular function, whether it's positive or negative, there's a correlate of that in the brain. Of course, over here, we're looking at precise movement. So we're looking at motor programs. This blue area, I feel like we're playing, what's that game? It's not
Twister.
Which one?
Twister.
Twister?
Is it Twister?
I don't know, but I like Twister.
Me
I like
too.
Twister. Let's stick with Twister. It feels like we're playing brain Twister. All right, so motor programs, this area in blue, that is where the portion of the frontal lobe programs movement. It plans for movement. So this is where precise movement is controlled. That has a relationship with the cerebellum, as you can see as the pathway going down and the green pathway going into the cerebellum and midbrain. Part of this green pathway is postural control. I'm going to stop there. What I'm trying to get you to appreciate is that there's different brain regions that are responsible for these functions. Chris, before I complicate things even further, is there anything you want to say about this?
Just really an emphasis of the fact that gait is a very complex process to execute, both physically through the muscles, joints, and lower part of the body, and also to coordinate and plan from the brain. So, you know, gait is just, that's why it's such an important parameter for us to focus on today.
That's right. So I'm seeing in the chat Operation. I don't see any Monopoly. Simon, perhaps. I think the game I was thinking of was Sorry, because it has those big. Have you played Sorry?
No.
The Canadians here must have played Sorry because they're always sorry. You know. Anyway, all right. Let's move on. So another one, right? Let me bring back my laser pointer. So as we have sensory signals from external and internal environments, it can go both to the limbic system and the frontal cortex here. In addition, as we have feed-forward information, which can also be from the sensory environment, and we have information sensory coming from the spinal cord and the peripheral nervous system, that can go up through the thalamus. What I want you to appreciate is the connection, this whirlwind of blue connections and pathways linking the more posterior and deeper and frontal cortical networks together. So they're not exclusive. What I want to say about brain function and brain anatomy is not this part does this and this part does this. It's more about functional brain connectivity, just like, it's not so much about the gastrocnemius as it's more about the posterior chain. Consider this the brain posterior chain, right? This is what goes up through the spinal cord, communicates to the frontal cortex, and interrelates to each other, okay? And I will say that emotional processes do play a role, and we don't want to get too airy-fairy about it, but we will talk about emotion and psychology briefly in the context of fall prevention.
No question. And part of that is fear, right? I mean,
Big
fear
time.
Is one of the biggest predictors from an emotional standpoint for future falls.
And I have another surprise slide for you, Chris, about that later on. It's not going to jump out at you. Don't worry.
Can't wait.
So what all this is trying to demonstrate is that gait and motor impairments, especially DTC, which stands for dual task cost. Dual task cost is when you introduce a dual task, and whether it's postural control or gait, it slows down. It's negatively affected by a dual task condition. So if you have higher dual task cost, if you are slower in your gait, and if you have motor impairments, that can contribute via slow gait velocity to falls and fractures. We know that. Bidirectionally, we have this relationship of cognitive impairments, which came first. Well, it's a chicken and the egg, not or the egg. From the cognitive impairments, we have mild cognitive impairment, vascular cognitive impairment, perhaps mild cognitive impairment with Parkinson's disease that can contribute to dementia syndromes, which also has a bidirectional relationships with falls and fractures. All of these have common brain networks that are shared, all of which are affected by aging, neurodegeneration, normal and or abnormal, vascular brain disease, which we're looking to prevent via the modulation of cardiovascular risk factors and other factors as well, like genetics. So it's complicated, but we know that it's interrelated and we should have an appreciation for its interrelationship. Therefore, it's not more important to prevent falls or more important to slow cognitive decline. It's equally important to address both independently and collectively. Right, Chris?
Agreed. Yeah, fully agree. It just, they depend on one another. They relate to one another, and they're connected in so many different ways.
That's right. So to further relate different aspects of the brain and different aspects of gait, We're going to show a couple slides on this, but let's talk about gait pace, gait rhythm, gait variability, and gait asymmetry and postural control. Chris, do you want to very briefly define each one of these?
Wow. I did not expect having to do this, Ryan. Assist me, please.
So gait pace.
I want to make sure I'm in the same language as you.
So what is gait pace? How would we define that?
Gait pace would be essentially your velocity.
Okay, got it. And then rhythm, is rhythm the same thing as variability, or is I would think variability as the variability throughout the gait cycle, right?
Correct. So rhythm would be more things like symmetry, would be things like amplitude, would be things like where we're able to dissect the actual cycle itself and determine if the parameters, the measures are the same, right side versus left side.
It's really the timing of it, right? And then we have asymmetry, which you're talking about, and then postural control. So we can extract all of these qualitatively and or quantitatively. We know that, right? And so this 2017 article is saying that what can quantitative gait analysis tell us about dementia and its subtypes? And it linked pace and rhythm to Alzheimer's disease. It linked pace to Lewy body dementia, which is really common amongst those with Parkinson's disease. And it also linked pace to vascular dementia. So it seems that pace is really the mediator here. And let's say that pace would be synonymous with speed. Is that fair to say?
That is fair, yes.
So without getting too complicated, it seems that speed has its relationship with dementia subtypes. So just by looking at gait speed, which will show you how to do, it is very valuable, not just from a mortality and from a physical aspect, but also from a dementia aspect and also subtypes of dementia aspects. So it's pretty important. Taking this even further, pace seems to be related to brain function as a whole, executive functions, which we have defined in memory. It doesn't mean that you can't just look at people walk slowly. It's like, your memory is bad, you have dementia. It's more correlation, right? So please don't go diagnosing people. And then variability in rhythm. Well, variability specifically seems to be related to global cognition. Rhythm does seem to be related to memory, as does pace. And then asymmetry and postural control, they don't have any arrows here, but they are also important.
Yeah, no reason, or definitely not to discount the importance of variability and rhythm in terms of the sorts of exercise challenges that we should be implementing with our clients. So
that could be rhythmic challenges. That could be gait variability itself, having a lot of movement variability, changing the pace of things. And, it could be intra-session, meaning that it could be inside the session that we're giving rhythmic-like activities or variations on tasks that we have, whether they be gait or balance-oriented, or it could be rhythmic modalities like dance, right? And so we can almost prescribe these things perhaps as fitness professionals for people to hopefully get improved adaptations, both neural and physical. What I'm very excited about is that I'm very spoiled. I work in an institute where we have brain imaging, quantitative EEG, cognitive testing, biomechanical analysis, and we can start to parse these things out in assessment and be able to give very precise exercise technique and exercise modality prescriptions for that individual's brain health. And that's the future I imagine as technology exponentially becomes more affordable and accessible. That will be in your purview, if you wish it to be, as a health and fitness professional, especially if you're creating a medical fitness practice with a specific eye towards brain health and neurological wellness. Fun times. So in terms of looking to have the most brain health oriented program, we need a lot of demands, right? And a lot of variable demands. We're not going to go over every single one of these, and we have introduced these regions of the brain already, but we want to have all of these lobes fed, if you will. So we want a variety of cardiovascular exercises, cognitively demanding exercises, resistance training, sensory-rich activities, object-based activities, visuospatial demands, motor control demands, attention demands. coordinative exercise, skill exercise, in skills where the things you're engaging in are rather unpredictable. I think we could take each one of those characteristics. Yes, we can theoretically link it to specific brain health outcomes, which is what my course is about. But more importantly, it's yielding a rationale for better ecological validity in our training, meaning that we want to integrate things like objects, visual attention, coordination, skill, resistance, cognitive demands, and cardiovascular demands into our training so that we can get the most brain health benefits, most neurological benefits. And I think I know there is research backing up the physical adaptations, both the cardiovascular and the neuromuscular benefits of having a variable program like this. Chris, is there anything you want to say about that?
Well, I love this schematic here because it really emphasizes the multi-modality training that we're very strongly promoting.
Exactly.
We cannot just focus on one type of training because we may not then adequately recruit or put a challenge or demand both metabolically, glucose metabolism, or just from a neural activity standpoint, regions of the brain. So we need to really provide a lot of different exercise modalities so that we are fully conditioning the body and also stimulating the brain.
It's truly nutrition for the brain and all aspects of it, as well as the body. And I think the opportunity here is to look at, well, what am I not integrating? Because there's so many fitness professionals out there that say they work with older adults and they just do static balance challenges. It's so basic. And remember, this is really vouching for that somatosensory variable input. Let's give them a taste of the real world as in many ways and as much as we can. And that's why I try to treat my patients like athletes, not physically in the sense I'm pushing them beyond their capacities, but give them a lot of variety of these inputs and open skills and coordinative demands. I think we need to think more along those lines. So this goes to show you that auditory rhythm on music and gait disturbances can make certainly a difference here, especially in Parkinson's disease. We're not going to talk about Parkinson's disease, but perhaps this will give you an appreciation, at least in relation to gait, that external cueing, whether it be auditory, visual, or sensory inputs, communicate to motor programs, which communicate or execute the gait program. There is a modulation of internal pacing via sensory feedback that goes to the basal ganglia, the sensory motor area, and then back up to the motor program. So there's this feedback loop. This feedback loop is disrupted in Parkinson's disease via the basal ganglia, and therefore what I would call an environmental aid or stimulus, such as rhythm via an auditory rhythmic stimuli like music, can actually really be helpful. It also has its unique cognitive benefits. Research has recently been done comparing exercise classes with and without music, and the ones with music have more cognitive benefits. And so it's not to say that you should do music all the time. It's not to say music is the best and everything else isn't, but it is to gain an appreciation for external cues, especially those for that may be visual, rhythmic, sensory in general. It's not to say one is better than the other, but they're all essential brain and body nutrients. Of course, we, in addition to Parkinson's disease and dementias, we can have ataxia, which is a clinical dysfunction of the nervous system to coordinate movement, specifically in the cerebellum. So we would certainly be looking to address coordinative demands and more cognitive and dual task demands in ataxia. While we are not going to go over how to address it, and certainly neurological physical therapists would be keen on addressing this, I think it's important to talk about the conditions related to gait in the neurological system that you might encounter. Earlier, we talked about specific brain regions. Here we are talking about brain networks. This is more where neuroscience is going. This is like the functional anatomy of the brain, just like we have the functional anatomy of the body. We have the default mode network, which is sort of the daydreaming, mind-wandering network. We have the salience network, which switches between the two. And the second one is the central, the two that it switches between is the default mode and the central executive. The central executive engages your conscious brain to think and maintain attention on a prioritized task. So I'm going to ask a trick question in which I'm not expecting an answer, but which one's better for fall prevention? It's actually none of them, but I would argue that the lack of negotiation and alternation of these brain networks might be what causes falls. So are you mind wandering when you should be paying attention? Are you paying too much attention out of fear when you should be mind wandering and allowing automatic processes to take place? Is your salience network not properly switching between these two different networks, right? So functional brain network modulation, while we're not yet able to look at it, well, at least we can in research, and there are EEG tools that are pretty affordable, but I will say it's likely that everyone here will probably not be assessing this in real time. So it's important to give you an appreciation for these brain networks, that they are complex, that it's not just insert stimuli here, address that brain region here, we are done, fixing human. It's very complex in the way that we have these functional brain networks. Their activity can be modulated via different sensory inputs. There's also the sensory network. There's just many different networks here. Chris, is there anything you want to say about these networks?
Yeah, I mean, the quotes that you posted earlier about the circumstances where people report falls, that is high. Most of those were linked to kind of an overactivity of default network. But again, on the flip side, people who become hyper vigilant as they're moving through their environment and trying to overly consciously control movement, where they're really like massively overly dependent on their central executive network, right, may find themselves in similar types of issues and problems. They might just not even be aware of other stimuli that might be coming at them that then can override and put them at a major disadvantage. I mean, it's one thing to be focusing on lifting and placing your feet, but if you lift and place your feet and you step out into an intersection when you're not supposed to, that creates its own set of issues.
And that's why I send all my patients into the intersection the first time I meet them. I'm just kidding, I don't do that. But yes, it's a good theory to maybe recommend that, perhaps you're biased in one network and maybe it's more appropriate to be in another one at a certain time. Now, you're not consciously thinking about this, but what you do have consciousness over is conscious control. And we are able to teach conscious control, but sometimes we need to teach unconscious control via distraction. We're not going to get into what affects these brain networks, but they are affected by aging, and they're very complex, but we appreciate they exist. We recognize their existence. We thank them for who they are. All right. Another set of neuroimaging. We're not going to go deeper into this because it is very complex, but you get $1 for every time I say complex. But visual, somatosensory, and auditory all have their own unique networks as well. They all contribute to a multimodal integration network that contributes to these cortical hubs, okay? And so as we have proposed visual input, there's the occipital lobe, somatosensory, and auditory, right? The auditory, there's the medial temporal lobes and the sensory strip. The medial temporal lobes are right underneath your ear. There's the somatosensory with the motor strip having the most heat, the red being more brain activity. And so I think it's important to appreciate that we can almost imagine that as we give this stimuli, these areas light up, right? But what we're really looking for is a multi-domain approach in which we can give a lot of different types of sensory input. Another graphic to drive this home is that we have sensory input, we have attentional demands, we have cognitive demands, we have response inhibition, which is slowing or stopping ourselves from doing something. So the acceleration and deceleration of the body is a very important skill, but there's also a cognitive aspect to that where people can't slow down fast enough or they can't stop themselves from certain movements or behaviors. All of these contribute to the default mode network, or at least they are affected by the activity of the default mode network. That could be a good or bad thing. Then we have the insula, which is responsible for interoception, the amygdala and hippocampus responsible for memory, perhaps involved in the salience network, as is the cingulate cortex and attention. So this is trying to relate these different brain regions to these different networks, non-exclusively, but also if we look at, don't worry about the brain anatomy, but we look at attention, we look at cognitive control, we look at response inhibition, sensory, emotion and memory. how can we integrate these demands into our balance and gait training programs? That's what I want you to take away from this. I know this is overwhelming, but it has a lot to do with brain health. And from this paper, it's talking about environmental sensitivity. And really the point of training gait, balance, and cognition is to better interact and survive and hopefully thrive within our environment.
Yes, and if we go back to that adaptive capacity model from way at the beginning,
yes,
we essentially evolved to ambulate for a specific goal-oriented purpose that required us to be out of our default network and into our salience network and into other networks. So if we just train people where they can be in their default network, stand on one foot and daydream about something, it's not going to result in that enriched sort of a environment that will maximize recruitment and therefore activity within the brain.
Yes. So if you are overwhelmed, it's because this stuff is complicated. All right. And I think what Chris and I have gained an appreciation for in preparing for this pre-conference is how beautiful these systems are and how much we really have to learn about them. So when you integrate the neurology component, it's almost like a whole new world, right, Chris?
Yes, it
right?
is.
I was going to sing to you, but I don't want to, I'll do that on the break. We'll serenade you. But it really feels like, okay, we almost have, there's always more gait and balance techniques to learn, both in assessment and training. In the fitness industry, can sometimes feel we've seen it all, right? But when you add this layer, it really is starting from scratch almost, or at least layering neuroscience onto what you understand. And that's our hope, is that we can integrate other fields like neuroscience into kinesiology and exercise science, apply it specifically to geriatrics and aging, and hopefully prevent things like falls and cognitive decline and neurological conditions, so that we can be happier, healthier, and just live together in a positive way. I'm going to, before I tear up here, Banyo break. I've overloaded your brains. Cup your eyes, cup your ears. Say, I don't want to listen to Ryan anymore. Let's say we come back. It's a 1:54 PDT. Let's come back at 2 p.m. Or do you want to do longer than that?
2 is perfect.
So about 5 minutes, all right?
Letting you know that every assessment that we discuss today coming up are validated assessments. They are used out there. And what we're going to do is just kind of give you an idea of when and how you can best utilize these assessments for your clients, so that you get a better sense of their cognitive/physiological function as it relates to balance and gait activities. So Ryan, anything you want to add there?
Nope. I'm excited to get into this. I'm seeing some questions that actually will be answered soon about dual task ability, how to measure it, how it can be improved, can it be improved. I also saw a question about the central pattern generator, which is too complicated to get into defining for this, but essentially the central pattern generator theory has to do with the oscillatory connections of brain networks as it relates to automatic functions like walking, and as it relates to sensory input. So it's a great question. If you really want to learn more about it, just go to Wikipedia, central pattern generator. You'll learn a lot about it. It's very complex and interesting, but for simplistic purposes, it's basically what we presented. Gait is interlinked with oscillatory brain activity that changes based on the sensory input that is given or in the environment. With that said, there are ways to assess aspects of that via assessment. I'm excited to get into it. So we're going to talk about both dual task and balance assessments. So we'll talk about the timed up and go, the timed up and go cognitive, the timed up and go manual, and the mythical timed up and go triple.
Ooh, wow.
We're going to talk about the 4-square step test and the 4-square step test cognitive. We're going to talk about walking trail making test A and B. We're going to talk about the walking Corsi block test. We're going to talk about, I don't think we will talk about the 4-stage balance test.
Okay.
We're going to talk about the STAR excursion balance test and maybe how to integrate dual tasks. We're going to talk about the functional reach test, but for this one, we'll talk about ideas for dual task variations. We might talk about the dynamic gait index, all dependent on time. So we're going to go over what all of those are. But before we get into it, I wanted to give you guys some examples of questionnaire-based assessments. I think, aside from a PAR-Q or a generalized intake, personal trainers rarely use questionnaires, and it makes me so upset. But one of these, this questionnaire is actually a dual task questionnaire. Do you have any of these difficulties? Paying attention to more than one thing at a time. It could be very often, never, so it has that scale there. Needing to stop an activity to talk. Being unaware of others speaking to you when doing another activity. Following or taking part in a conversation where several people are talking at once. Walking deteriorating when you are talking or listening to someone. Busy thinking your own thoughts, not noticing what's going on around you. Maybe that has a relationship with that default mode in salience network negotiation. Spilling a drink when carrying it. We'll talk about how to assess that. Spilling a drink when carrying it and talking at the same time. Bumping into people and dropping things if doing something else as well. Difficulty eating and watching television or listening to the radio at the same time. These things that you may do, that you may take for granted, they change with age. They change with neurological conditions. They can be predictive of accelerated aging or certain conditions to a degree, according to some correlational research. So there are dual task questionnaires. In addition, there's the activities.
Excuse me, Ryan, real quick. Could you just put the title of is there a title to this questionnaire? Is there a name of it?
It's just called dual task questionnaire.
Could you put that into the chat real quick?
I will, yeah.
But then go to the next one. I can talk about the ABC.
Yeah, we're going to be having in addition to the PDF of this presentation, we're going to send some links out that may have been mentioned as well.
Right.
So we'll have the dual task questionnaire and the ABC. Go ahead.
Fantastic. So the activity-specific balance confidence scale, this is a scale that is oftentimes utilized. You'll see it in almost, not all, but a fair number of research articles looking at the effect of an exercise training program on balance. Generally, they will look at some functional outcome measures such as timed up and go, such as gait speed, but also subjective measures that give an idea of a person's change in a person's self-efficacy as it relates to their balance capabilities. So the ABC scale really is meant to have a person determine how confident they are to maintain balance in different situations. And they would rate anywhere from 0%, I absolutely positively would fall if I were to find myself in this situation, all the way up to 100% where they would say, I am 100% confident of my balance. There's no way I'm gonna fall. I can do this basically super, super easily. And we noticed through the 16 different items that they all tend to be, first of all, ambulatory activities where there is movement occurring, oftentimes where there are maybe not necessarily a lot of implied or directly stated cognitive elements to them, but they're sort of implied that there are cognitive elements, such as walking in a crowded mall, walking while carrying parcels, walking on slippery floors, or another version talks about being out on icy sidewalks. And those sorts of tasks in the activity-specific balance confidence scale pretty much determine or require there to be significant cognitive elements present as well. And we generally find that in response to a well-tailored balance training program that does include dual task activities, people tend to score better on their outcomes of the ABC scale than if they're doing more just default network balance activities like standing on one foot.
I mean, who's not confident walking on slippery floors? Come on.
Love it.
Yeah, I do it all the time. It's my favorite hobby, actually, is walking on slippery floors. All right. So you want to talk about these assessment strategies, Chris?
Sure. So what we're going to do is both from a assessment standpoint and also from a programming standpoint during the rest of the pre-conference, we're going to introduce essentially the physiological assessment. So the basic physiology needed or responsible for scoring well on these validated assessments. And then Ryan is going to add in, okay, well, how do we add in cognitive elements? When is it appropriate for us to add in cognitive elements? And what can we derive in terms of meaningful information when we look at perhaps the physiological assessment itself versus the physiological assessment being done in tandem with the cognitive challenge. So what we'll start with is introducing the physiological assessments. And then from there, we'll add that additional layer with how we can add cognitive challenges to that. Okay, so two of the primary and best assessments, in my opinion, truly to dial in on balance capabilities and reducing fall risk are the functional reach test, which is more of a static balance assessment, and the timed up and go test, which is a dynamic balance and gait assessment. So these two really work in tandem very, very well to give us an idea of what a person's overall fall risk might be in essentially any situation that they might encounter, whether it's a stationary reaching sort of task or an ambulation task. So the functional reach test has been validated since 1991 by good old Duncan and colleagues. Pam Duncan came up with this thing. Okay, we're going to watch a little video of it, and I will kind of voice over or talk over the video.
I was born when the functional reach test came out, man. It's emotional for me to watch this thing.
It's amazing. It's good stuff. Okay, so here is the reach test. You've got it on silent too, right?
This is the reach test. This is an assessment of joint mobility.
Did you want to narrate, Chris?
Yes, you can. I'll narrate it. I'll narrate it as we go through.
You know what? Actually, I know you can do this for YouTube, but for Vimeo, I cannot silence you.
Oh, wow.
I've never seen it. You are your own problem. You want yourself to shut up, but you can't. It's amazing. So let's just watch the video.
I've been accused of that. Then we can wrap it up after the video.
For sure. Here we go.
This is my father-in-law, by the way.
This is the reach test. This is an assessment of joint mobility and static balance. I have Alex here today to help demonstrate the reach test. We have a yardstick on the wall directly at shoulder height. What we're going to have Alex do is stand with his feet shoulder width apart, his left hand at his side. Alex will make a fist with his right hand and lift it up at the height of the ruler. We'll make sure his shoulders are square. Take an initial measurement, 21 inches, and now he'll reach and hold his finish position. 12.5 inches, stand back up. So that was an 8.5 inch reach. We would then check on the left side as well. Great job, Alex.
Boom.
Boom. Okay, so functional reach test. Basically here we're looking at, it's a limits of stability measure. So we're looking at how effectively he can move center of pressure in an anterior direction as he's doing this forward reaching task. Now there's a lot of physiology and a lot of physiological requirements that go into doing this test effectively. Obviously we see him hinging at the hip. If we don't have good posterior chain flexibility and also good motor control of the posterior chain, there's no way that he's going to be able to effectively reach. We need to have good joint mobility throughout the entire kinetic chain for him to effectively perform the reach. We need to have him be able to control the speed at which he reaches, hold his endpoint isometrically, and then return to the starting point. So we need also some muscle strength, muscle power, and isometric control capabilities. There's a lot of stuff that goes into that functional reach test. And ultimately, the goal is, based on normative comparisons, we're going to find out how an older client does relative to a comparison population, and from that get a good sense of what their static balance capabilities might be. Now, there's not a lot of vestibular or visual challenge associated with this test unless we decide to layer that onto the test with some additional challenges. And also, there's not really a dual task responsibility or challenge in this test unless we decide to add on some dual task challenges as well.
That's right. And if we added a dual task to the functional reach test, it would not be validated. There's no normative values for it. So you could almost look at it as training techniques. But if we want to look qualitatively at how a dual task or a visual input works with this, changes in center of pressure and postural control. Because I will say it's also a postural control task, right? They have to reach forward and control their trunk. and stabilize and come back, right? So there have been studies taking reaction lights out in front of them and to their sides, in which they have to reach at a certain speed, and then they bring the lights further away, so they have to reach even farther. Some ideas for training this might be throwing a ball so that they have to reach forward and catch it. Of course, you want to make sure that they're not reaching outside their limit of stability, maybe inside, and kind of edge it out to the outer aspects of that limit of stability as it's safe. So there's a lot of ideas for adding those visual and cognitive layers to it. Now, Chris, did you want to define center of pressure versus center of balance or gravity?
Okay, so we've got three kind of centers. We've got center of mass, which really is a location within the body. We generally think the center of mass is like basically just deep to the belly button. That's essentially the center of where all of our mass, depending on stature and different body frames. But center of mass is like an anatomical location on the body, whereas center of pressure and center of gravity, essentially those are interchangeable, is where our center of mass is positioned over our base of support. So if we've got our feet at hip or shoulder width apart, we basically just take that center of mass, project it directly down, and we'll find that generally when people are quiet standing, it is approximately at the center of their foot. So it would be about halfway between toe and heel. Now, obviously, as we perform a functional reach test where we're hinging forward, the center of gravity and the center of pressure migrate forward as our center of mass migrates forward. So you can use center of pressure, center of gravity interchangeably, and that is the ground location over which the center of mass is positioned relative to other body parts, namely the feet. If you're on your hands, it would be relative to the hands. Okay, here we go. Now the next one is the timed up and go test. This is our dynamic balance and gait assessment. We'll watch this one. Obviously some more task demands associated with it and more movement skills associated.
This is the walk test. This assessment is our assessment for gait enhancement and dynamic balance. I have Alex here helping me with the walk test. What we're going to have him do is see how quickly he can walk around the cone, come back and sit down. Here's what the test is going to look like. Alex is starting the test with his feet flat on the floor, his hands on his lap. When I say go, he's going to stand up, walk as fast as he's comfortable around the cone, come back and sit down. I'm going to time him on the stopwatch to the closest 1/100th of a second. That's it. Alex, let's do this test. I will give you a ready, set, go command. Ready, set, go. Around the cone.
Go, Alex, go.
And come back and have a seat. 8.92 seconds. Very good.
Well done, Alex. Okay, so gait assessment, dynamic balance assessment. He's going through open space. He's performing a turn, so he's changing direction. He's having to decelerate. He's having to accelerate on multiple occasions, accelerating after he stands up, out to the cone, decelerating around the cone, accelerating back to the chair, turning around, decelerating and sitting, not to mention the strength requirements, both concentric getting up out of the chair and eccentric controlling getting back into the chair. So this is a great assessment that gives us an idea of his balance capacities and his gait as he's moving through open space. We can evaluate from a more, aside from just the objective, how much time did it take him to perform this test, we can also look at things like stride length, stride symmetry. We can look at whether he favors turning in one direction or another, differences in time between turning to the right and turning to the left. All of that provides us even some more information about the specific gait mechanics that we might observe. Perhaps there's an issue with him where the left foot clears the ground very effectively, but he generally always will shuffle or scuff on the right foot. So that would be an effect of the swing stage of gait on the right side. So we'd be looking at joint mobility of ankle and hip. perhaps
also neurologically be asymmetry, right?
Absolutely, no question about it. And a lot of that stuff can be mediated neurologically, like a drop foot, something like that is a neurologically controlled or neurologically determined gait abnormality. So the cone is 3 meters away. Okay, so that's 9 feet, basically 10.5 inches, 3 meters away. And there are 2 different versions of this test from just looking at the physiology of it and an outcome. You can either have them walk at their usual speed, or you can walk at a rapid speed, fast as possible, while being safe. We generally like to see how effectively somebody is able to move through space while pushing their physiological limit. So we ask them to walk as fast as possible.
All right, so now let's look at how we are going to take the timed up and go, and we are going to give it a dual task, and it is a very validated test, even with normative measures. We're going to talk about that, but first let's talk about, and we'll mention it in this video, it's going to show some dual task assessments, but it's also going to show some other interesting things as well. So let's watch this video. Oh, awkward. Here we go.
Which comes first? Does exercise lead to better brain health, or is it the other way around? And can improving a senior's mental capacity by playing brain games help increase his or her mobility? Ursula Perry reports those answers come from a study that's the first of its kind.
Okay, begin. 73-year-old Marlene Ray knows all too well that aging is tough on the body and the mind.
My sister-in-law suffers with dementia, so I want to know what I need to do to help anybody else I can while my mind is still sharp.
Ray is one of more than 400 seniors being recruited by researchers at Albert Einstein College of Medicine for CREM, the Cognitive Remediation to Improve Mobility Study.
And it's based on the idea that to walk in the real world, you need to engage your brain.
3 days a week for 45 minutes, half of the seniors in the study play computerized brain games that target the areas of the brain important to mobility and executive function. The prefrontal cortex, the basal ganglia, and the connections in between.
A, C, E, G.
Participants then perform timed walking and cognition tests, seeing how long it takes to walk a runway while reciting alternate letters of the alphabet, or finding a way out of a floor maze while keeping one foot on a yellow guideline. Marlene, who performs with her church, says since beginning the program, she's seen a big improvement in movement and memory.
I did a show in December with my choir. We did and I had to remember 12 songs.
We hope to see at the end of the trial that we would have reduced the amount of effort the brain has to do while walking. In other words, making the brain more efficient.
As part of this study, scientists are using special scanners to measure the amount of brain activity. A small study has already been completed showing the participants did improve their ability to walk. Now a larger randomized study is underway, and it should run through the year 20.
All right, so very interesting. This will also show you that young, middle-aged, and older adults all have distinct dual task abilities. So let me get my schmancy laser pointer out.
Okay.
Laser. All right, so here's the 10-meter walk test while doing a serial 3 subtraction, which just means counting backwards by 3s from a random number picked between 20 and 100. That's how you do the timed up and go cognitive. We'll talk about that. So whether it's serial 3s, serial 7s, typically I'll pick serial 3s when serial 7s are too challenging. Doing that in a timed up and go context, 3s and 7s, and doing that in a 4-square step test context with 3s and 7s. You can see that specifically for the 4-square step test, middle-aged older adults took a little bit longer than older ones, but when we added a 7, that was not so much. So we're not going to talk about why, but you can see the staircase. This is time on the left-hand side. So we see it takes people longer, generally speaking, as they're older, and you can almost group the middle and older with the younger to see that young adults really have this dual task ability and they do it well. So it's important to start early, maybe 30s, 40s, 50s, doing this type of training, especially in older adults. And even if they have cognitive impairments or a neurological condition, dual task is a trainable skill set. You can train dual task ability at any age for the most part. So we see that there's a very clear difference as a marker of aging. So it's a great biomarker. All right. Let's look at now how to use the timed up and go and add a cognitive layer. The timed up and go cognitive is very validated for Parkinson's, MS, mild cognitive impairment, and looking at the risk of Alzheimer's disease, people with Alzheimer's disease, older adults, younger adults. So this has a lot of data. This is one of our go-tos, just like the timed up and go is. At the end, you're going to see that the timed up and go and the timed up and go cognitive, their two primary outcome measures are time, and there are ways to calculate the difference between the two.
What we're going to do now is we're going to superimpose a cognitive task on the tug. So we're going to ask Bruce to do a cognitive task while he's running this same test. There are a variety of different ways to do this. We're going to start with a math task, and we're going to see how Bruce does with a math task. In the clinic, when I'm really trying to get good data on this, sometimes if I have somebody with me, a PT tech or an aide, I'll have them jot down the answers that somebody's giving. So I'm going to have Bruce do a serial subtraction. So we'll do that here. I'm going to give you a starting point, Bruce, and then I want you to do some math as you're walking. From the starting point I give you, I want you to subtract 3, and I want you to continue to subtract 3 as you're going, okay? So you're going to do this test, but I want you to do this cognitive task while you're doing the walking task, okay? Good?
3 from where?
I'm going to tell you where to start if you tell me you're ready. Are you ready?
Yeah.
Okay. I'm going to have you do that subtraction, and I want you to start at 99. Go.
99, 96, 93, 90, 97, 94, 81, 79. That was terrible.
Okay, so you heard some errors in his math. So there was some decompensation from the cognitive task as he went. His timed score was at 8.92 seconds that time. And so we really saw when there was the divided attention or the demand of both the motor task and the cognitive task, we had some decompensation in the cognitive task. You heard him go from the 90s and then stay in the 90s, I think, when he intended to get into the 80s. And he had a little bit of slowing of his gait as he was, as we compared this to his previous scores.
And the previous score she's talking about is just the regular timed up and go. All right. So here are the normative values. We will send resources. I like the Shirley Ryan Ability Lab in terms of looking at all these different assessments where they really spell out how to do it. So the procedural knowledge. So we are teaching you conceptual knowledge. At the end of this webinar, I wouldn't trust that you're just about ready to apply all of these tests tomorrow. You probably want to revisit the procedures, make sure you're doing them right, make sure you're timing them and scoring them correctly. But I will say that I think it's important to present the cutoffs. So at least for fall prevention, if people who do the tug alone and it's greater than 13.5 seconds, depending on the normative ranges you're looking at, that if it's greater than that or greater, it's a higher fall risk or a high fall risk. For the tug cognitive, it would be greater than 15 seconds. And for the tug manual, which we're not going to show a video of, but it's just the tug while you're holding an almost full cup of water. So it's a motor dual task. One motor task is holding the cup of water, trying not to spill it, right? As you're walking, the secondary motor task is the walking. So it's motor, and then cognitive motor. So anything greater than 14.5 seconds for the tug manual puts you at a high fall risk. Now, then there's the tug triple, where you do the cup of water while counting backwards by 3s or 7s while walking as fast as you can. That's a fun one. So we're going to have a competition later, perhaps.
Big time. So yeah, really, really good to show some norms. So when you're assessing your older clients and you start noticing either one of the measures being worse than kind of what our fall risk cutoff happens to be, or there being a really large discrepancy between the tug alone and the tug cognitive, that should kind of get ourselves thinking that, it's an area that really needs to be worked on. So Ryan, let me pose a situation for you. Let's say that the tug alone person goes 6.5 seconds. Good, like way below the fall risk cutoff. And their tug cognitive is 12.5 seconds, still below 15 seconds, but now there's a 6-second gap between the tug itself and the tug cognitive. What would your thought process be in evaluating that person?
That's great. So another thing we will send you in the follow-up email is actually how to calculate what is called dual task cost. So it's actually an equation. I didn't want to post a math equation and walk us through how to do it, but it's essentially the dual task. So what was the time you gave for the single?
6.5 and 12.5.
Okay, so it essentially be, it would be 12.5 minus 6.5 divided by 6.5 times 100. And you would come up with a negative percentage, because you get a decimal, you carry the decimals over, you get a percentage, it's going to be a negative value. So let's say that's like a negative 60%, right? Or 40% or what have you. That would be a 40% dual task cost. That is something that you can write down, calculate, document, etc. Yes, many people want to know if they're normal. You can use normative values. For the tug cognitive, there is normative values, but they're less certain than the normative values for the tug. So you can say, oh, you just want to say, well, you're below 15 seconds, so you're not at a high risk for falls. Let's see if we can, and we did see about a 6-second differentiation between those two. Let's see if we can get that maybe to a 4-second or a 2-second. So it's taking the curiosity of, am I normal, with all the potential anxiety that's packaged with that, and turning it into a goal. Whether it's normal or not is not within the context or scope of this discussion or this presentation. I will leave that to an offline investigation of normative values. And the reason I'm saying that is because it depends. I don't know who you're working with. If you're working with someone with mild cognitive impairment and they didn't know it and you didn't know it, telling them they're normal might make them think they don't need to get a cognitive evaluation, for instance. So you could be doing more harm than good trying to give them that answer. So I just say it's relative. Let's see how low we can get that, right? And we're just about to finish writing the case series of about 10 patients from the Brain Health Center that I work at, taking people in a 12-month or 12-week intervention of dual task training, showing they significantly improved their dual task performance, whether it was traumatic brain injury, Parkinson's, multiple sclerosis, Lewy body dementia, normal healthy aging, or mild cognitive impairment. So a really mixed bag of patients. So dual task ability is trainable and it is sensitive to this type of training. 4-square step test. The way this works, and we will send you once again more resources for how to do this. You start in square one, you go clockwise 1, 2, 3, 4, 1. And once you hit 1, you go 1, 4, 3, 2, 1. So you go clockwise all the way around, clockwise all the way back. Once you've returned back to 1 for the second time, the time stops. So you just see how long that takes. I believe it's another 15-second cutoff for this as well for a high fall risk. Even without the dual task, this is a visuospatial demand where they have to use spatial memory to, those numbers are not there. They have to superimpose them and remember the choreography and the numbers in the sequence. So there's some practice that needs to take place here, especially for those that are more physically and or cognitively impaired. As soon as 1 foot touches the 2, the time starts. As soon as they get back to 1 for the second time, the time stops. Adding a dual task to this is recommended after they've practiced. Of course, they've done it for 3 trials. Then you're gonna say, okay, I'm gonna add a dual task. You can start with 3s if you're confident, you can add 7s. The only reason I wouldn't start with 7s is if they feel very self-conscious about their abilities. Like, oh, I can't do that, I can't do math, or you have some cognitive issues, for instance. Another alternative task, for instance, although this is not as well researched, is saying every other letter of the alphabet. Some people have said, well, I'm really good at math. Is my time going to be different with a different cognitive task? And then I give them the serial 7 subtraction, and then I give them the other letter of the alphabet task, and they're actually the same times. So I find that interesting. So lots of interesting ways to add a dual task component to this. It's a great dynamic balance task. And sometimes I'll pick up balance issues in this test, even just in the single condition, whereas some people are just really good at the timed up and go, or the Berg, or the 4-stage balance test. Anything you wanted to say about that, Chris?
No, I mean, I've always loved Foursquare test because it's so, there's a complexity to it that really requires a lot of attention, and also a lot of movement skills such as changing direction. So it also really results in a lot of agility and dynamic balance requirements as well. So
it's very cognitively demanding. Chris, I think you had a personal experience with this test. Did you not?
I did. I'm not going to go there.
Okay. I was so close to putting that video in this presentation, but I didn't want to embarrass you. I'm trusting you're working on it.
I'm working on it all the time.
Another thing that we might be familiar with is the MCAT-SIB, or the Modified Clinical Test of Sensory Integration and Balance. Before I go into this one, Chris, did you want to describe the MCAT-SIB?
Oh, from Fullerton, one of the big Fullerton tasks. Do we have a slide on that, right, Guy?
We don't, but essentially it's standing with your feet on the AirX pad with your eyes closed, right? Eyes open, eyes closed, solid.
So it's basically more of a field test to determine somebody's sensory organization. So there are some force plate, balance platform, instrumented sensory organization tests where people are standing on an instrumented force plate that moves, or the surround they're looking at moves. Very valuable to start determining and to determine whether it's visual, vestibular, or somatosensory deficits that have the biggest effect on that person's balance issues and their risk for falls. So basically the field test equivalent is the MT.
That's right. So there's studies where they take that test and add a cognitive component. So tandem stance with eyes closed, either on a hard surface or an AirX pad. Numbers auditorily, they have numbers 1 through 10 randomly said, not in order, just it could be 1, 7, 2, 8. And if it's even, they click a button in their right hand. If it's odd, they click a button in their left hand. So they're using their auditory attention and responding, and that creates more postural instability. So you could be doing, this could be for assessment or for training purposes, that they could lift or clap or tap the side of their leg. This is a technological integration. It's an application to traumatic brain injury in the military. So it's not necessarily, this study at least is not directly applicable to your practice, but the concept certainly is. Okay. There's another test where these are dots on the ground. So looking at the one on the left over here, this is called the trail making test. The trail making test is an actual neuropsychological test. I go 1, 2, 3, 4, and you're just walking through these, where actually typically on paper, you're drawing a line, and that is a cognitive test. That's called the trail making test part A. This is just the practice because it's very easy just for people to get it. Then the trail making test A has more of a visual search component. So 1, 2, 3, 4, 5, 6, 7, right? You have to go through. Trail making test B is 1A, 2B, 3C. So you're set shifting or task switching. Someone asked earlier, can the brain truly multitask, or is it just task switching? Well, it can do both. It can dual task, but sometimes when people say, oh, I'm watching TV while I'm on the computer typing something, that is a task switch. But walking while talking is a true dual task. Those processes can exist separately. To assess set shifting, the trail making test B is usually used. Now, how do you do this in your clinic? Well, I've gone on Amazon, or your studio, I've gone on Amazon and got little dots of their classroom based equipment usually, and they have numbers 1 through 24, and I'll just randomly spread them about within a defined area so there's not too much variability from test to test. And then I do that with 1A, 2B, 3C. I'll actually time them to see how long it takes. In addition, there's the walking Corsi block test. So the Corsi block, normally on pen and paper using just blocks, they'll put these blocks on a table and they'll tap them in a certain position or sequence rather, and you have to tap them in that same sequence. So it's kind of like Simon in that way. And if you get 2 right, then it goes to 3 and 4. So you're constantly increasing that memory demand. While you may not have this magical flooring, I have used speed and agility ladder squares or pieces of tape to actually create this. And I'll take a laser pointer and point to them in order with 2 to 3 seconds for each one to be illuminated, or I will actually step on them and then they repeat it. And the choreography gets longer and longer. The most challenging part about this task is you remembering what you actually told them to do. So I'm serious. No matter how smart you think you are, it's very difficult to come back to this. Now, once again, you will have the PDF of the presentation. We're going to send you the web links for these tasks. Then there's
agility dots work really well as well.
They do. They really do. No, in the brain health trainer course and some of the videos you'll see, I've just taken colored agility dots and taken permanent marker and drawn on them. That works very well. Chris, did you want to talk about the STAR excursion balance test?
Yeah, so the STAR excursion balance test, really, really good test for, I mean, essentially it would be a static balance test because we've got 1 foot in the center of the star or the center of the testing area that is stationary. You're staying balanced on it while moving in multiple different planes of motion with the free leg, or what we consider to be the swing leg. And what the STAR excursion test is really good at determining, and from a biomechanics perspective and a physiology perspective, is really looking at hip mobility and looking for differences in hip mobility between sides or differences in hip mobility between different planes of motion. So it's possible that you may find somebody who has a really great lateral excursion on one leg, but really poor lateral excursion on the other leg. You may find somebody who has difficulty balancing during a posterior reach on one leg, but balances really effectively posteriorly reaching on the other leg. So it's a good measure of both stability of the stance leg and mobility of the free leg, and can give us an idea of where there might be asymmetries in stability or mobility. However, we can also add some additional challenges onto that.
That's right. So you could imagine if we look at the axes that this individual is standing on, many of you have heard about the clock task, where you actually assign a clock position to each of these areas. So 12, 6, right? So on and so forth. So you could actually have this individual balancing and you're calling out these different numbers, and they could have them marked. So it's more of a reactionary task, or it could be more memory oriented where they have to almost consciously project these numbers in their mind onto the ground in the order that you say them. And there actually is an app called Clock Yourself that we'll present earlier that could help with this. Now, that is not an assessment that's been researched as much, but it is a great task and a good way to add a cognitive layer to see maybe how are the biomechanics changed by distracting the individual. All right, here's a tandem gait task. She is going to be giving her a tandem walking task and presenting to her a language task. She's going to give her a word that she has to spell backwards. Okay, so let's see how this works.
3, 2, 1. Apple. E-L-P-P-A. River. R-E-B-I-R. Elbow. W-O-B-L-E.
So more qualitative than perhaps quantitative, but just some ideas to get more ways of assessing dual task ability, okay? So our main areas of assessment for here are posture, gait, and dual task ability with some mobility, but it's also important to assess strength, mobility, and breathing, although that is not the context of this session, but it is the context of our lovely counterparts having a pre-conference at this time, Evan Osar and Robert Lingle. So some of our assessment process, this is just an example. This isn't saying that you have to do this, but if you were to take all of these assessments, let's say you're already working with your clients, you want to apply these assessments to your clients to see where they're at, or you want to add this or some of these to your intake process for new clients. In addition to questionnaires that you might select, like the activity-specific balanced confidence scale or the dual task questionnaire, we have all the ones that we've gone over. So, and we have their measures and we have what it assesses. So the functional reach test, the timed up and go, the timed up and go cognitive, the 4-square step test, the 4-square step test cognitive, the star excursion balance test, and maybe the tandem gait with dual task. Now, pretty much all of them are for time, except the functional reach test is for distance. With the star excursion balance test, there's various measures. You can make it qualitative and or qualitative. Same thing with tandem gait. We're not going to talk about that here, but I think it's helpful because you can look at dual task ability in the context of gait and dynamic balance and agility, look at gait speed, agility, and balance, both static and dynamic in various contexts, postural control, mobility. Chris, what do you want to say about this?
Just how adaptable and how comprehensive these assessments can be when we're looking at the integration of different components of function. So it gets us to think assessments aren't just only focused on one particular performance parameter. We can look at assessment as really the integration of a number of performance parameters and how they work together.
That's right. So let's quickly go over, now that we've gone over assessments, the rest of our presentation for the most part will consist of programming. So let's introduce the variables behind that programming. I think we can take a quick break. Let's see how we feel, and then we'll dive into programming.
Got it. Okay, so as mentioned earlier, when we look at gait, we have these different phases of the gait cycle, some of which the swing phase requires mobility of hip and ankle, and also other joints of the body as well. So as long as we have good rotational capability of the upper body, that has an effect on things like stride length and also amplitude of the foot off the ground. Other physical domains of gait include muscle strength and muscle power. Again, at foot strike, the ability to eccentrically absorb the force that is offered up by the ground. And during push-off, concentrically propelling the person off of the ground. Muscle strength, muscle power, very, very important for gait. Cardiovascular endurance, no question, especially if we're doing a longer gait task, such as a marching test, a 6-minute walk test, 400-meter quarter walk test. And we notice as somebody starts to fatigue from a cardiovascular perspective, it has an effect on their gait mechanics. And then finally, agility and balance. Clearly, there is a responsibility of agility and balance and an incorporation of agility and balance while we are modifying a number of gait variables. So if we're changing direction, changing speed, speeding up, slowing down, changing the rhythm to match with whatever the environment might be demanding or the task might be demanding, that really is where we're getting to changing directions and maintaining balance effectively. So there's a bunch of different physical domains, all of which need to be incorporated into our training programs to ensure that the person can perform gait in whatever situation life throws at him or her.
Now for the cognitive domains, there's of course more than this, but for simplicity's sake, we have attention, which could be visually or auditorily attending to things, or it could be both simultaneously in a sustained, selective, switching, or divided capacity. So sustained is you're paying attention just to that one thing with no distractions. Selective is you're trying to filter out distractions in relevance to that stimulus. You could be task switching between stimulus or dividing stimulus, which is dual tasking. For processing speed, that's like reaction time or how quickly things are processed. For executive functioning, we defined earlier. It's more complex and has a lot of subcategories. Impulse control or inhibition, cognitive flexibility, planning, organizing, etc. And then memory, there's different types of memory, verbal, visual, procedural. Most of what we're going to address is what's called working memory, which technically is a part of executive functioning. It's the short-term memory storage of things that usually get stored later. But memory, generally speaking, is the encoding, storage, and or retrieval of information. Okay? And there are different types of stimuli. Of course, there's vestibular, there's visual, there's somatosensory, and there's auditory. And those can have varying levels of cognitive load. As we introduce those cognitive domains, it's not flipping them on and off. They're more like volume knobs. You are a cognitive wicka DJ, and you are trying to assess and train these different functions. And so if I'm throwing someone a ball, the visual attention knob is turned up a little bit more, but it's not that complex. So executive functioning is turned down a little bit. If I'm doing the 4-square step test or a choreography-based activity, the memory is going to be turned up a little bit. so on and so forth. And of course, we want to be aware that we have these loading matrices. So this is giving some ideas of how to progress and regress things. Generally speaking, there's a framework for this. They can progress or regress individually or collectively. So if we follow the dotted line, physical and cognitive are progressing together. If we go across horizontally or vertically, they are progressing independently. So physical load and cognitive load can interact in this way. Of course, we want to introduce balance, or sorry, not just balance, but cognitive and balance and gait challenges relative to their skill levels. So if we introduce a task that's, oh, I learned all these great things about math and balls and this shaking your head back, and it's too challenging, they're going to get anxious or frustrated, or you might knock them unconscious. So do be careful. Yeah. The other thing is that if it's too easy, it said, look, I can have you walking while adding up by 1 and go 1, 2, 3, 4. And they're like, dude, I'm 58. What are you talking about? Right? And they're bored. So we want to get a balance of those two things.
And that's really what we want to strive for with our programming. We want to make sure that we are appropriately and accurately assessing our clients so that every single one of them, we're providing a level of challenge that matches with their current level of skill. That way they're in this flow channel. And we know if you're in this flow channel, then that's going to provide the most optimal stimulation during exercise. It's going to be the most enjoyable, and it's going to provide the most likelihood for adaptation. If we overload them and get way up into anxiety, it's not just overloading them and making them anxious. There's just simply way too much stuff coming up to the central nervous system for it to be able to process and figure it out. So therefore, the motor responses are going to be crappy. And if there's not enough information coming up into the central nervous system, again, we sort of go into that default mode, and the person is off in space thinking about what they're going to have for dinner that night during your training session. And then again, that doesn't provide a benefit. So keeping them in the flow channel and using our assessment results to ensure that we're selecting the right level of challenge is really kind of the key to the most optimal program design for each of our clients.
Very well said. And in addition, there's these psychophysiological benefits of doing that. If we keep them in this flow channel, there's more rapport, there's more motivation, there's all these beneficial neurotransmitters that are released. So it behooves us to do this. And also behooves us to go to the bathroom.
Woo-hoo!
So when we come back, we are going to go into combining brains and balance, really what you came here for. Let's say it's 250, 3 PET. Let's start at 3. We'll zip through and we'll wrap it up with some programming. Is it possible to do this for ourselves? Yes, it's possible to do it for yourselves. We have technology, we have techniques, we have ideas, Randy. We will help you out. All right, let's go on break. We will be right back with your regularly scheduled programming. All right.
Several different drills. So what we really want to inform you all about initially is that, similar to the flow channel, we do not want to throw the whole kitchen sink at all of our clients right off the bat. It's great to think, let's provide some really challenging balance and gait exercises in these incredibly enriched sensory motor environments, and throw in all of these difficult cognitive challenges. And boy, we're just going to get so much bang for our buck. We need to always ensure that we are at the right place at the right time with our clients. So the way that we're going to proceed with this section is I will introduce the balance drills. The balance drills that then we can add additional layers onto, and Ryan will talk about dual task layers and
all that baloney.
Yeah, consisting of various different cognitive challenges. But if the person cannot perform the balance drill itself with a decent amount of efficacy, you'll hear it either called the 80-20 rule, or I call it the 75% rule. The person should be able to successfully, with concentration and effort, perform these drills well 75% of the time. And maybe the other 25% of the time, they're a little bit off kilter and off balance. That is a great level of competence from which they will adapt physiologically, and a good time to start layering cognitive challenges on top of it. But if they're overwhelmed and it's too challenging physiologically, then adding cognitive challenge, you're not going to benefit in either the physiological or the neurological realm. So we're going to introduce the balance challenges first and then layer on top of it the cognitive things. Ryan, sound good?
Indeed.
All right, sounds great. Okay, so when we really look at the physiological parameters that are going to relate to balance training and fall risk, there's substantial evidence that points specifically to certain types of exercise, certain training components that need to be in a person's training program in order to move the needle on reducing fall risk. So even though, yes, absolutely, cardiovascular training is super important, static stretching can be super important for various outcomes that we're looking for, there's not really any evidence to suggest that those reduce a person's fall risk or benefit their balance. Yoga and Pilates, there's probably just not enough research yet to demonstrate the effectiveness of yoga or Pilates on reducing fall risk. My belief is as more research gets done in those areas of training, we will eventually find that yoga and Pilates both have an effect on reducing fall risk. There's just not academic research yet that backs it up because there aren't enough studies out there. However, the things we definitively know help to reduce fall risk include joint mobility and stability. Again, having joints that move through a good range of motion, but also can be stabilized so it can load ground reaction forces and accommodate the force the body is sustaining when it makes contact with the ground. Sensory stimulation, improving our visual and vestibular function, getting those to integrate more effectively in order to inform the central nervous system to a better degree and resultant better motor plans. Muscle strength and muscle power, no question, both for stability during movement and recoverability during stumbles, trips, things like that. Static and dynamic balance, focusing on ensuring that we have adequate ability to move our center of pressure with control, move our center of pressure either from one foot to another or across a displaced area as we walk. And then finally, enhancing a person's gait, getting them to focus on changing gait strategies so that they can be ready for whatever gait task they might need to produce in order to keep their balance in any situation. And clearly a lot of those things are evident in our Tai Chi training. So Tai Chi has oftentimes been shown to be a very, very effective fall risk reduction training technique.
And for enhancing cognition, especially when you're doing Tai Chi while holding a cup full of chai tea. It really is the best intervention.
Tai Chi.
That's spelling that backwards. Okay, anyway.
I love that. Okay, so what we're going to go through is a few different exercises that are specific to fall risk reduction. First one is what we would consider to be a stationary vestibular challenge. So again, stationary, meaning that what we're wanting to do is challenge static balance. And static balance is oftentimes challenged not just by standing on one foot, but having some other movement requirement that the body must accommodate. In this case, it's accommodating a vestibular challenge by turning the head and mixing up those inner ear structures we talked about earlier. Run it, Ryan.
This is a level 5 sensory stimulation exercise called turning head from a tandem stance on an unstable surface. It's a very challenging exercise, being a level 5 exercise. So we have 3 balance maintenance mechanisms within our body. The sensation of our feet on the ground with our sensory receptors, the inner ear, and also the eyes and the vision. All of those work together to give us ourselves an idea of what the body is doing and how to maintain its balance in whatever situation we might confront. So to train these systems, what we need to do is challenge at least one, if not even 2 of them at a time. And that's what we're doing with this level 5 exercise. So what we're gonna do, I'm standing on this unstable surface. It's a foam pad for me. You might wanna use a pillow or some towels, just something to give you a sense of instability underneath your feet. And we're going to then go into a tandem stance. left foot forward, right foot back. So the left foot is forward, the toe of the right foot is touching the heel of the left foot. And now I'm simply going to start turning my head back and forth at a relatively rapid pace. This is mixing up.
Okay, fantastic. So in this exercise, even though we're in a stationary static balance position, we are creating some balance challenges, that limited base of support, and also the fact that we have a compliant base of support is going to result in somatosensory input up to the central nervous system saying, whoa, I am in a very unstable situation. Pressure receptors, as we kind of shift our weight in this balance challenge stance, is going to be constantly informing the central nervous system. And then the head turns, mixing up the ear, getting fluid to move in the vestibular system, is going to create additional sensory input coming in from the vestibular system into the central nervous system. So we're really challenging the central nervous system with two of the three balance challenge mechanisms having additional sensory input coming into the CNS. So we really are using our vision, which has just looking straight ahead, very basic challenge associated with it, is helping us to integrate the additional challenge on the other two. Okay, Ryan, good. Anything you want to say there?
Yeah, so if we were to think about adding cognitive challenges of any kind to this, we'd probably start off the AirX pad with a semi-tandem stance, then tandem, semi-tandem on AirX, then tandem, making sure you could do that, introducing cognitive tasks at each point. And perhaps you could artificially create the vestibular demand, or you could just create task switching between several targets in which you're naturally turning your head because of goal-oriented behavior.
Right. Perhaps those head turns could be in response to odd or even, over to the right's odd, and then you give them a quick equation. They're turning their head to the right if it's odd. They're turning their head to the left if it's even. So just those targets that result in that head turn can be cognitively challenging. And as Ryan mentioned, it is true. We do have, like, our level 1 exercises are in touch with the an external support in a more of a hip width stance. So we would want to see the person being able to have 75% effectiveness before we move on to the next challenge. Okay, now we're going to be talking about dynamic balance, where we're actually seeing a movement of center of pressure through what's called a rocking feet exercise. So let's play this one, Ryan.
This is a level 2 dynamic balance exercise called rocking feet. This is a great exercise to help us learn how to establish dynamic balance. That is our ability to balance our body in response to motion. So we're going to move and establish balance. This is a really important thing for us to do on a regular basis and helps us reduce the risk for a fall by helping us recover our balance after motion. So here's how we're going to do this exercise. We're going to offset our stance. I'm putting my right foot forward, my left foot back. I'm going to put my hands on my hips. I'm going to shift my weight forward. I'm going to shift my weight back. Shift it forward and balance. Shift it back and balance. Forward and balance, back and balance. I'm rocking my feet. A great way for us.
Okay, so good. I'm blanking. Thanks a lot. Okay, so here we go. So again, sagittal plane of motion. We also can do frontal and transverse plane of motion with the rocking feet exercise. So this is more dynamic balance, where we see the center of pressure and essentially changing from one foot to another. If we progress this exercise, it goes to a step to the front, a step to the back. We're actually getting step to balance, step to balance, step to balance, step to balance. And then our final progression could be a hop to balance forward on the left, a hop to balance backward on the right, and continuing in that sequence. So we can add the balance challenge on a dynamic exercise, dynamic balance exercise like this. And then clearly, Ryan, let's talk about some ways that we could add some dual task responsibility.
Yeah, the first thing that comes to mind is perhaps adding a serial 7 calculation task where you're counting backwards by 7s, every other letter of the alphabet task, but also maybe you're continuously doing this rocking task as you're throwing a ball back and forth. And so maybe there's a task switching paradigm by which you have to keep the rhythmic rocking going as you're catching a ball. And there's this rhythmic mismatch where perhaps the ball and the rocking are at different intervals of rhythm, if you will. They're unrelated, and you have to keep managing both. In addition, this is really well set up for what we call directional callouts, left, right, the clock callouts, adding in compass directions, north, south, east, west, and the ones in between, saying north, but then reversing it so they have to step south, things like that. And so adding the progressions you talked about on top of that would be a great way to integrate some cognitive challenges as low-hanging fruit. All right, we'll go on to the next one here.
Yes, fantastic. Okay, so this is more of a gait enhancement drill, which requires, and it's opening. So here we've got moving through open space, a little bit more challenging than just a dynamic balance, very small amount of displacement. Here we're moving through open space and providing a little bit of a novel gait challenge, a sort of gait training exercise. They might not typically be moving in this manner, but the more they can establish and maintain control while moving in kind of unique gait patterns, the better it's going to affect their ability to maintain their balance when they have to draw on unusual gait strategies to respond to what they bump into in their environment. So go ahead.
This is level 5 gait enhancement exercise, moving in the forward direction, called zigzag walks to balance. Great exercise to train our gait to the way that we walk. While we walk, we want to always be in control of how we move our body. This is a must when it comes to resisting and reducing the risk for a fall. So this exercise is going to be fantastic for that. Did you hear that?
That was pretty loud.
That guy accelerated hard.
Is that supposed to
Oh, no.
Is this the wrong video, Chris?
I sent Ryan a blooper video. Son of a gun.
Why don't you just explain what's happening here, Chris?
Okay. I'll turn it this way. Ryan, you can turn that
Oh,
off.
here, I'll put it on mute. I think we can hop around here.
There we go. So basically what we're going to do is a diagonal step. Step together, balance. Step together, balance. Step together, balance. Step. Okay. We got by the blooper. There we go. Okay.
It is muted, so you can narrate it if you want.
Okay, so we're doing a step together, essentially a diagonal forward step to balance. Obviously, we could also incorporate, there's a lateral or a lateral frontal plane gait enhancement exercise as well, very similar. And the goal here is just to provide a little bit more of that reactive static balance response after a high knee gait step. So we're throwing in just a few additional elements. There's a static balance element that needs to be incorporated with that single leg balance, and also some reactive balance in response to the movement. So there's acceleration, deceleration, and also.
What are you attempting to do with your hands there? Is that a semi-pelvic thrust? What was that?
No, this is saying like stop. So you
okay, got it.
Stop and hold the static position. Stop and hold the static.
Understood.
Okay. All right. So Ryan, obviously here, lots of potential opportunities for cognitive involvement as well.
Once again, one similar to before, especially with the directional callouts, the left, the right, and then you keep going. But when you have a snap or a clap, you stop, right? Or you have different verbal inputs or auditory inputs. You're behind them perhaps. And when you say X, they keep going. But when you say Y, they stop, right? And so you could have this continuous auditory input. They have constant auditory attention, but they have to actually differentiate between an X and a Y, or a color, or an odd or an even number. Alternatively, you could be in front of them, so visually you're showing them something, maybe numbers with your hands or colors with cards or something of that regard.
Got it. Perfect. Okay, and then here is our top level integrated vestibular challenge and gait challenge. Let's play this one, buddy.
This is a level 5 sensory stimulation exercise called zigzag walk with a turning head. This is a challenging exercise because we are challenging our three balance maintenance mechanisms, the sense of our feet on the floor, our inner ear, and our vision. And by training these systems, the way we want to do that is by removing or challenging at least one of them at a time. This exercise will challenge two of them at a time, making it pretty tough. So what we're going to do is we're going to turn our head back and forth. This is actually mixing up our inner ears. By keeping our eyes pointing forward, it creates really only our vision assisting us, especially since we're going to perform a zigzag walk at the same time, which is going to challenge our balance with our lower body as well. So here's how it's going to look. We're going to start with that shifting head, turn that head back and forth, and now I'm going to perform a zigzag walk. And I'm simply zigging and zagging as I turn my head back and forth. Zig and zag, zig and zag.
I think you were doing this on the streets of San Francisco when I first met you. I said, I think that man needs medical assistance, right? That's how we became friends, I believe. Is that right?
Hey, I got to tell you something. I'm not sure who's visited San Francisco recently, but when you're walking, especially down near Civic Center where I get on and off the train, man, you need to have your head on a swivel. It's an interesting place. So you're going to be looking out for all sorts of weird stuff happening. So, I mean, you know, you look at this exercise, and not only do we have a novel gait pattern, the weaving gait pattern, a little bit later in the video, we won't go to it, but I also talk about adding additional layers, such as cueing somebody to speed up, cueing somebody to slow down, cueing somebody to stop, cueing somebody to accelerate, to decelerate. So we can add more layers on an exercise like this, which will then create even more of that kind of requirement of being cognitively engaged and reacting to other stimuli that's given to them, whether it's auditory or visual. Okay, go ahead.
No additional comments there, but I think we will.
Eyes are forward, by the way. You want to always keep your eyes in the direction you're walking and turn your head, okay? So you're overriding the vestibular ocular reflex, which generally has the eyes track the direction your head is turning. In this case, you use your vision to help you with your balance. So you kind of look at a fixed object that you're moving toward. Okay, go for it, my man.
Oh, I will say that's
who has problems with because they get dizzy. That's where we start to get the habituation element of vestibular training. You probably wouldn't go to this drill right away. You would just get them to start getting comfortable with very small, slow amplitude head turns, perhaps in a balanced challenge stance or while marching in place. And over time, as we go through vestibular rehabilitation therapy, they start to habituate and accommodate that more. And you can eventually get them to the point where they aren't getting those symptomologies doing a more challenging exercise. Go for it, my man.
So on top of that, that is different than gaze stabilization, right? Whereby with gaze stabilization, you might give them a finger or a target to keep their eyes locked on with head turn, right? And I've done drills where we are doing that movement and they may be walking zigzag with head turns, but they're keeping their eyes fixated on a single point and or moving that target that keeps their eyes fixated. So there's a visual saccade, if you will, and that's happening. Or a switching between, so the eyes dart from this finger to this finger, and they're not turning their head, but they're looking.
Right, shifty eyes. They get the
shifty eyes, right? That's pretty good. All right, so now we'll go to these dual task drills, and you'll retrospectively get more ideas of how to apply some of these to balance. And Chris, of course, you'll chime in and talk about how to add more balance demands. Of course, as we talked about the 80-20 principle, before we add dual task conditions, make sure they're relatively proficient in the physical task. Otherwise, you propose injury risk. And do keep in mind this skill learning component whereby you introduce it. If they're quote unquote bad at it, at a novel skill, it doesn't tell you anything about their brain. They're just learning a new skill, right? So don't be judgmental and don't let them be hyper judgmental about the introduction of a novel task. Keep in mind the cognitive, associative, and autonomous phases of skill learning. All right, let's start with a very basic reaction time drill where we're using our visual input and object, AKA a ball.
fast feet movement. That's going to be more of a cardiovascular progression for this exercise. But I'm also going to add more of a reaction time demand on this. So I'm going to have you place your hands behind your back. I'm still going to call out left or right, and each or either the left or right hand will come out based on what I call. Okay.
Okay.
So let's practice this without the quick feet, really quick. Okay. So left, left, right. Good. Make sure it goes behind the back again after every repetition. I don't want the other one coming out to say hi, just the one that I call. All right. Right. Good. All right. So let's start the quick feet movement. Get a little bit more of a cardiovascular demand. Try to stay in place. Left. Good. Hand goes behind your back. Right. Left. Right. Left.
Okay. So, of course, this is a progression. You didn't see what preceded this. But this is a cardiovascular demand. Chris, we could probably add a tandem dual task, right? You could even be zigzag walking. You could really apply this to anything.
Yep. For static balance, put them in a staggered or a tandem stance. For dynamic balance, have them doing a step to balance. For a gait task, have them doing high knee stepping or narrow wide stepping.
That's right. You could do so much with this. And I think besides just throwing the ball back and forth, having the hands behind the back and calling out which hand comes out is even more complex. If you want to go even further cognitively, you could add association. So if I say an even number or odd number or a certain color or a fruit or a vegetable, or species of dog versus species of cat, you know, pit bull versus, tell me your favorite cat species, Chris.
Russian blue.
Oh, very nice. Isn't that a drink? I thought that's a beverage. Anyway, all right. Let's move on. You get the idea. This is more of a balanced demand, as you'll see, taking some hints from the STAR Excursion balance test. All right, so for the next exercise, we are going to introduce more of a balancing task, of course, with different cognitive stimuli. And so as you can see on the ground here, we have my very highly technological dots with permanent marker written numbers on them. And so just to show you that there's, of course, products out there that have different visual cues that can be ground placements, this is a nice way to provide a low budget version. So there's no excuses to provide cognitive demand here. What Lucy is doing, she's positioned in the middle of these are in a cross pattern or a square pattern, and she's right in the middle. And this is going to be more of a balancing task, Lucy. We're going to have you float your foot. And if that's too challenging for you, you can just take the front toe and just kiss the ground for stability, but you're still providing more weight on that left foot. And I know you said balance is an issue for you, and so that's why I wanted to provide this task. We're going to start with an attentional style of cognitive load here. So you're going to be looking at my hand the whole time. Okay. So we have these dots on the ground here, and I just want to make sure that you know you're using your spatial memory to remember where each of the dots and numbers are. Yep. So what's in the front here? 1. 1, and in the back? 2. And over here? 3. 3. 4. Very good. You didn't have too much practice, so that tells me your short-term memory is quite good here. Okay. So what we're going to do is have you reach to each number based on what I call. So if I say 1, or I put 1 up, you reach towards 1 and you come back, okay? So right now you're just touching the toe down to the ground to make it a bit more physically easier for you or accomplishable. And then if you want to make it harder, just float your foot, okay? Just float your foot if you want to increase that demand. Does that sound good? Yes. Okay, so I'm going to be showing you the numbers. Okay. So this is a visual input, right? I could be calling out the numbers, and there's a portion where I will actually do the auditory and the visual, where I will say 4, but hold up 2 at the same time, and she has to either A, bias towards my visual, or B, bias towards my auditory based upon my instructions. So this could get very complex, right? That is like a Stroop task. That's right, where you show the color blue, but it's in the ink red. So we actually can take that and give it an auditory, visual, sensory, motor Stroop, right? It's pretty creative, I'm not gonna lie, but there's a lot of ways you could take these types of stimuli and make them more progressively complex. And I think, Chris, what would you do to make it more physically demanding?
I mean, more physically demanding, a lot of options. You could actually, instead of having it be, so she's like stepping out and tapping, correct?
Correct.
Okay, so you could actually add something like, all right, you're going to lunge to that target, or you're going to squat to that target, or you're going to, you know, if you want to have them doing some sort of like a a core task. Maybe you've got them in a plank and then they're lifting the hand or lifting the foot to tap the target. So you can throw on additional physiological challenges depending on what you want to accomplish during that particular exercise.
Put them on an RX pad, perhaps. Instead of just keeping that central foot there, you could go into that progression where you're stepping or hopping to that target, right?
Yeah.
And here's a working memory drill. It's more about, it's very regressed. It's just using two directions, left or right, but it's adding working memory load. So let's check this out.
Now I'm going to add a bit more of a memory demand for you, okay? I'm going to give you a sequence of steps. It's either going to be left or right, and I'm going to sequence them out, okay? So I'm going to say them, and you're going to have to keep up with them. So for example, if I go left, right, left, show me what that looks like. Good. Nice. So a bit more choreographical demand, if that's a word, right? Okay. Now I'm going to give you longer streams. So if you can do that well, I'm going to give you longer streams of numbers, or sorry, left or directions rather, if that makes sense. Okay. So left, right, right, left. Good. And then what I'm going to do is, before you finish that last repetition, I'm going to start with the next series. Okay. So you're really going to have to attend and use your memory. Right. Okay. Right, left, left, left.
So you can see I'm progressively adding working memory demands. I could use odd or even numbers, all the examples I gave prior. We could add RX pads that you're stepping on. And of course, we could add anterior and posterior directions to
planes of movement, changing, exactly. Yeah.
Absolutely. Okay.
So much fun.
They are a lot of fun, especially if they are progressed and regressed properly. When you get people in that flow state, these are client retainers, not the things that go in your mouth, but they retain your clients because they're so much fun in addition to having their own therapeutic value. All right. More complex. It's the last one I'll show you here.
I'm going to switch up the numbers for you. Okay. So now this is 3, this is 2, and this is 1. Very good. Okay. And instead of saying the numbers,
so you're going to see a few things. There's a few pieces of equipment. There's an RX pad on her right-hand side, a ball in front of her, and a hurdle on the left, right? So we've added some variability. Her answer key is the 1, 2, and 3 dots that have 1, 2, and 3 written on them, but are also different colors. So see what happens here.
Say the colors, and then you're going to have to match those up. So if I say pink, what do? Very good. Awesome. If I say green, no. That's right. Very good. Okay. And if I say yellow, good. So scale of 1 to 10, how cognitively demanding?
Really hard.
Okay. All right. We're going to move pretty fast. Okay. I think it's difficult, but I think you can do it. Okay. Right. Are you ready? I'm going to give you a string of colors here.
Okay.
Yellow, green, yellow, pink.
So not only does she have to use her executive function and processing speed to look at the dot, see what color it is, associate that with the number, associate it with which direction or movement she was supposed to be able to do. I was also adding on working memory load of going pink, yellow, green. Now, this is at the end of several, quite a lot of basic introductions of these tasks. So it's a very progressed version, but it should give you an appreciation of how complex these cognitive stimuli can be. It doesn't just have to be spelling your name backwards in Spanish. It doesn't have to be these trivial things. We can take notes from cognitive psychology and actually structure these in a very interesting way. So I'm going to create suspension. You're not going to know how she does, but spoiler alert, it's challenging. But you'll see I was asking on a scale of 1 to 10, how physically demanding was that? On a scale of 1 to 10, how cognitively demanding was that? On a scale of 1 to 10, how frustrating was that? That's a tool called the NASA Task Load Index. All this and more you can learn by signing up for the Brain Health Trainer course today. All right. Self-promotion ended. Chris.
Hey, Ryan, we are at 3:31, but I think we can get through just some of the emerging technologies that people might want to be aware of in about the next 5 minutes. How does that sound?
That sounds good. I think I would like everyone, invite everyone to stick around. This is the bonus section, really. Right, Chris? This is the bonus section. We're talking about the future here, right? I know SpaceX just launched, but this is better. This is more exciting. Forget about space, all right? This is exciting stuff. So Chris and I are cognitive motor technologists. Is that fair to say, Chris?
I would say so. And what's interesting, we don't just know one another through fitness. We also know each other through our respective research groups.
That's right. That utilize
touching on what we do with our research here.
Indeed. So there's a few apps out there that I wanted to make you guys aware of. The first one is Switched On, where you can select the stimuli of colors, numbers, arrows. You can use it on the app. You can stream it to a screen during Zoom training. I have a whole training on how to do virtual brain training using this tool. In addition, Clock Yourself is another great one, taking that concept of the clock and using auditory and visual cues to get them moving in different directions in a dual task format. There's also substituting the clock numbers for calendar years, for astrology signs, for periodic table of elements. This is something they could actually use on their own as well. And then another clinical tool out there, mostly not for improving cognition, but for looking at falls prevention. And they use a lot more semantic or fact-based or trivia-based stimuli. But Nimble is a series of apps that applies to group training, clinical utility, and one-on-one assessment for assessing dual task ability for fall prevention. So all of these great apps out there, Clock Yourself and Switched On, are available for free right now. You could download them and start messing around with them. In addition, we have technologies like SmartFit, which I'll show you a video of, the Body Brain Trainer, which Chris will show you a video of. We'll talk a bit about the Dividot Senso, and we won't talk about NeuroTracker, but NeuroTracker is a computer program that could be screen shared or accessed on any device or in your clinic, at home, whatever it be. And it has multiple object tracking, so it's more of the visual stimuli. 8 balls, and they can be in 3D, wearing 3D glasses, or 2D, but even in 2D, they're still in this 3D box construct, and these 8 balls shuffle around, and you have to track 1 to 4 of them at a time, depending on the settings that you pick, with them incrementally moving faster based on your success rate. So I'll often have people stepping over hurdles or standing on one leg while doing this, and incorporating a lot of Chris's balance drills during this task. So it's a visuo-cognitive motor dual task. So let's watch a quick video from SmartFit. And you'll see this is specifically applied to active aging programming, and you'll see some balance drills here as well.
Now reach out for the D. Okay, so
that was much better, wasn't it?
I love it. I love it.
The reason I'm showing this to you is because enjoyment and gamification are really important components of being able to introduce cognitive and physical stimuli. SmartFit's one of my favorite tools. It's got about 50 plus different brain games, cognitive and dual task assessments. And it's one of the I'm very I believe proficient in generating cognitive tasks, but honestly, sometimes you just want to be lazy and have this generate the task for you and collect the data so you can focus on the client or patient. So I really appreciate this technology because doing cognitive tasks is cognitively demanding from the perspective of the trainer as well. So SmartFit's got individual targets in addition to these wall-based systems. Yes. And yeah, it's awesome. You can get people boxing, throwing. It's really a lot of fun.
That is awesome.
Over to you, Chris.
Okay, so a project that I've worked on the last 5 years plus at University of California, San Francisco Med Center, UCSF Med Center, with a group of neurologists there is the Body Brain Trainer research program, where basically it's gamification of physical and cognitive activities. So I'm going to show you a quick little video. One of my students who has since graduated and gone on to PT school is demonstrating the 3 different modules. The first module is a task switch module, Ryan has talked about task switching as essentially one of those dual task activities. And here the person is responding to the central target with a movement depending on where the target is. So you're noticing it's either a vegetable, a radish, or a carrot. He's either reaching up or down. It's a color, either blue or green. He's reaching to the side or the side. He's looking at this screen right in front of him, and he's responding with motion.
He's trying not to run into the antelope, is that right? Or the cactus? He's trying to avoid.
Yeah, he's trying to avoid the cactus and choose the correct target to either squat, jump, or reach to. And then we have a visual search challenge. So again, another element of attention and maintaining attention and focus. That's part of executive functioning. He is, and it doesn't show up too well because of sort of the staccato or whatever you call it with this, but he is actually reaching toward a green target in the direction the green target is showing. If it points up, he reaches up. If it points down, he reaches down. And then we have a working memory task. In the center, those different targets light up, and he has to remember the order in which they light up. And then after a latency period of about 5 seconds, he has to then hit the targets in the correct order. So this doesn't do it much justice due to sort of the pixelation or staggered response, but it's a very active game engaging different
elements. And also how it's collecting the exoskeleton of the Kinect camera as well as the gameplay, right?
Correct. And
it's really cutting edge stuff.
Who developed that game? Was that person on LSD? Because it is very...
Aren't we all? There's another technology called the Dividot Senso, which is like a clinical dance revolution. One of my good friends and colleagues, Bruin, is out in Switzerland, I believe. And his lab is, this is actually based on some research he did in his lab, Elling de Bruin. And this has actually transformed into a clinical product sold by HUR. They also make mnemonic resistance training equipment. And you can see math equations, there's reaction time exercises, there's a lot of different cognitive tasks in here. Of course, you can use the handrails, but you can also just stand freestanding there. You can remove the handrails as well. I actually lost all my weight as a kid on Dance Dance Revolution, but this is a nice clinical version as well. So there's actually research on this technology. Actually, all the technology we presented so far is research-based to a degree.
Yes.
Really cool stuff. So we're going to wrap it up. There's a lot more technology we could talk about, but we have lives to get back to, and so do you. So the optimal aging paradigm this Saturday, June 6th, 12 p.m. PDT, 3 p.m. PDT is going to include Chris and myself, but also 2 mystery guests. Do you know who they might? I don't know who they are, Chris.
No clue.
No clue, but I'm going to be talking about brain health. Chris will be talking about balance and gait. You will certainly hear about things we presented today, but most importantly, you'll see how they're integrated into a comprehensive model, including resistance training, joint health, and biomechanics for optimal aging. What is that optimal aging paradigm? Come with your curiosity. Let us create that suspense that you just can't wait for until Saturday, June 6th at 12 p.m., 3 p.m., PDT, EDT, respectively. Okay. Adjunctive education, of course, in addition to FAI, we have training the older adult from Robert Linkle, who may not be a part of that optimal aging program. I can't tell you for sure. The brain health trainer course, which is, not being biased here, but I highly recommend it. Mobility matters. Heard that's pretty cool, right, Chris?
Absolutely. Balance and fall risk reduction assessment and training.
Heard that's popular with the young kids nowadays. And then the integrative movement systems from Dr. Evan Osar, all great adjunctive education. And then the AgeWell Collective is something that Chris and I are a part of. You can go to agewellcollective.com. We're so excited to launch this. It's been a year in the making. Took a lot of Jimmy Johns to get this up and running. It's going to include structured weekly webinars throughout the entire year, comprehensive assessment strategies. I think Shelley asked earlier, will you integrate the assessments provided with resistance, postural, breathing, range of motion based assessments? Absolutely. That's what the AgeWell Collective will go over. What you saw today is just a toothpick of what we're going to present. A powerful toothpick nonetheless. One of those toothpicks that simultaneously freshens your breath even. Comprehensive programming approaches and monthly collectives where all 4 of us get together and chat about certain case studies as it relates to the knowledge we just presented. We also offer monthly Q&As. You'll be added to an amazing community of professionals in a private Facebook group, get additional bonuses, guest speakers, etc. So if you want to learn more, go to agewellcollective.com and sign up. Do not relent. This offer will not, well, actually, it'll be there throughout the entire year, but just do it now. Let's see. Okay, if you want to get in touch with us, agewellcollective.com, but individually, we have the brainhealthtrainer.com. There's my email, rglatt8@gmail.com. Chris, do you want to read off your website and your email?
mobilitymatters.fit, chris@mobilitymatters.fit.
Thank you, Siri. That is great. And also, Chris, I don't know if you remembered, but the last webinar we did, not with Robert and Evan, but with ourselves, you and I previewing this PreCon, we promised people a sword fight. Do you remember that?
No.
You don't remember? Are you serious? Everyone raised, I said, who would want a sword fight between me and Chris? And everyone raised their hand. So then I realized, I'm like, wait, we're not going to be in person. We can't actually do this. So I actually recorded a video of you and I sword fighting. I don't know if you remember doing
this is the surprise. Okay, let's see it.
It's over, Anakin. I have the high ground.
All right. For the non-Star Wars fans, I'll spare you. Anyway, I'll leave it on this page. Thank you so much for spending time with us. This was long, arduous, but hopefully beneficial and educational.
Yes. Thank you, everybody. Enjoy the conference starting tomorrow. Ryan's got his own session. I've got my own session. Then we have the session on Saturday, the collective session. And just enjoy it. And we look forward to seeing you all in person next year and seeing you virtually throughout the course of this coming year. So thanks so much for coming, everybody.
And remember, you don't grow old because you stop playing. You stop playing because you, no. I got that. Anyway, we'll see you soon. Thanks so much for your time.
Bye, everybody. I love this shirt. Okay, bye, everyone. Thank you.
Cup your ears, cup your eyes, recover. Recover. We're going to be here for another awkward.
Come on, Rye guy.
What? No, I'm just trying to get the